السلام عليكم. كل عام وانتم بخير، رمضان مبارك وربنا يعيده علينا وعليكم إن شاء الله، وكل سنة وانتم طيبين. Ladies and gentlemen, good afternoon. Happy Ramadan to everybody. It's our pleasure that we are going to start our webinar about COVID-19 and update refreshment about OB-GYN. First, I would like to say thank you very much for all our speakers. Thanks for Top House Conference for their actually help and arranging this one. Thanks to Bayer for their actually sponsoring this activity. So thank you very much. And I'd like to thank all the participants for sharing with us today about update and refreshment OB and gynecology. Thank you very much, everybody.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله جميعا. We will start our first talk with our prestigious speaker, Dr. Wissam Kurdi. Dr. Wissam, she is chairman of Department of Obstetrics and Gynecology, professor of Al Faisal University, consultant maternal and fetal medicine, Department of Obstetrics and Gynecology in King Faisal Specialist Hospital and Research Center in Riyadh, Kingdom of Saudi Arabia. Dr. Wissam will speak in the next 30 minutes about two topics. The first one will be pregnancy care during COVID-19, too much or too little. And the second presentation will be about reducing the risk of fetal anomaly. What is the role for the obstetrician? Welcome, Dr. Wissam, and it's all yours.
Good afternoon, and thank you, Dr. Samir and Dr. Samer and the organizers for preparing this mini symposium, and thank you for all the participants. I can see there is over 600 already now. So really thank you for taking the time from your weekend and Ramadan and everything to join us. So do I share screen? Yes? Samer?
Yes, start sharing screen, please.
I said share screen, but nothing is happening.
You have to open the PowerPoint first, Doctora.
It is opened. Okay, خلاص.
Yes.
Slideshow. Okay. So, so we're going to be talking about some like organizational ideas on how to actually take care of pregnancy during the COVID period. First of all, there are some facts that we know about COVID. Obviously, we don't know a lot about COVID. It only started a few months ago. So whatever information we have is from experience from other countries and some limited experience from our from the area around us. So in general, it doesn't seem that pregnant women are more likely to be infected than the general population, although we know that the immune system in pregnancy is a bit different and it's less, it's reduced immunity, and therefore it is likely that infections might actually cause, will be maybe caught a bit more with pregnancy, or it will cause more severe disease. And we know that from other infections, but that does not seem to be the case with COVID. Remember, there's a lot of asymptomatic people around us, so we have to keep that in mind when we are developing our care systems for pregnant women and for any patients, basically. And remember that people might only present with mild symptoms, which is something quite good. And so far, there has been no reported cases of deaths in pregnancy. There are, from what I read from the literature, maybe there are 2 cases where women were actually quite sick and they were in ICU care, but both had good recovery. So what do we know about the fetus? There is still, so far, no data that suggests there's an increased risk of early pregnancy losses. There is no data to support that it might be teratogenic. There is some limited data, maybe 1 or 2 cases where there was evidence of IgM in the newborn. And as we know, IgM does not cross the placenta. So if it is there in the newborn, it must be because he actually contacted the virus himself. But the significance of that has not been determined so far. Does it affect the pregnancy outcome? There are some reported cases of preterm labor, premature rupture of membranes. But remember that we know that in clinical practice, mothers who are potentially ill, they are more likely to actually have these complications. So is it really related to the virus, or it's related just because the mother is ill, or maybe it's even an iatrogenic preterm delivery? There are some criteria of population who are at higher risk of contacting COVID-19, and obviously pregnancy is one of them. So other high risk status could be like chronic mild to moderate respiratory diseases, heart diseases, kidney diseases, liver, neurological, diabetes, immunocompromised patients, overweight. And remember, all these are likely to be associated with pregnancy. So the pregnant women could be at an increased risk because of all these high risk categories. And there are some categories that are even higher risk, such as women with organ transplant, if they have active cancer, blood or bone marrow diseases like leukemias, severe kidney diseases on dialysis. And again, remember, we do see these patients during pregnancy and they have all these complications. So what do we do with antenatal care? I mean, at the beginning of the crisis, you know, everybody just went ahead and closed all the clinics, and please, you know, for your safety, don't go to the hospitals. How true is that? Can we just tell people, please stay at home and you don't need to come? If you are pregnant, even if you are a low risk woman, just stay at home and don't come for your antenatal care. How true is that information? Remember that care for pregnant and postpartum women is an essential service. So it's really not like an elective service. It is considered one of the essential services that we actually need to keep running in spite of any crisis. So they will need support, they will need advice, they will need to be seen in person in our hospitals. And so therefore, we really have to provide them with this antenatal care. And this could be, I mean, be innovative and like what we are doing today. So we are working outside the box nowadays. So teleconferencing, video conferencing, all this, you know, just to reassure the woman and to check if she actually has complications. So they should really be advised to attend their routine antenatal care, and I'll come in a minute to some, you know, practices that we should be not leaving out. And although, unless obviously the patient is in isolation or she's in contact with somebody with isolation, so maybe it's better to wait till she passes that isolation period and then she can come. Remember that, you know, we really have to go through our lists of patients. And if the patient did not show up for the last 3 weeks, we have to contact her. We have to make sure that she is fine. She might be too worried to come to the hospital, and that's why we have to reach out for these women. So I remember always, I mean, we always advise women on a healthy lifestyle, and especially smoking nowadays should really be avoided because studies have shown that it actually worsens the outcome. This is, you know, like a schedule that I found. There's a lot of policies and procedures and guidelines that were developed by all like international bodies, by even our local hospitals, definitely by the Ministry of Health. So this is sort of like the normal antenatal care that is practiced. So remember that, try to put appointments together, try to utilize one appointment to do multiple things. For example, I mean, we always tell women that we want you to come for a booking visit, and then we want you to come for the 11 to 13 weeks ultrasound. Just combine them together in one visit, where you can do the blood work, you can do the counseling, you can do the screening by nuchal translucency, and that's just one visit. We can skip other visits in yellow, which are sort of not really very essential for our antenatal care. Do not skip the routine, you know, maybe 20 to 22 weeks, 18 to 22 weeks, whatever is more suitable for your woman. So this is, again, a very important clinic visit. At 28 weeks is a good visit because we need to reassess all the blood work, maybe do the diagnostic test for diabetes and so on. And then later on, you can actually tailor your visits based on your risk categories. If she's low risk, maybe she doesn't need to come at 32 weeks. She can come at 36 weeks. If she's high risk, then maybe you need to see her a bit more. And obviously, everybody will need to be seen somewhere between 38 to 40 weeks, where we are going to start planning the delivery for them. Remember, there's a lot of comorbidities, like what I started off by saying. And in these women with comorbidities, you might need to see them in person a bit more than just seeing them by your teleconference. So if she's chronic hypertensive, for example, make sure that you see her at the beginning, where you can, make sure that she's taking the appropriate medications. You are doing all your routine investigations. You are doing your routine first trimester ultrasound. Advise her about blood pressure monitoring, maybe instruct her about the machine that she's going to maybe purchase from the pharmacy or something like that. And then you can continue doing some of the visits online and some of the visits in person. Preeclampsia is an important pregnancy complication, and you are more likely to face preeclampsia than you are likely to face COVID actually in your daily practice. So whenever you have a patient with a suspected preeclampsia, again, I mean, face-to-face visit will be very important. And again, maybe we should start, looking into things that we have always heard that they might be beneficial, such as the PLGF. So I'll have a few slides on PLGF in a few minutes. So, and again, I mean, you really have to give them the proper care. If she has early onset preeclampsia, less than 34 weeks, maybe she needs to be properly evaluated, maybe even, consider a delivery if this is what is indicated for the patient. For the PLGF and the SFLIT, these are important tests that have been developed, and they seem to be of value actually when you are talking about screening, either to rule in or to rule out preeclampsia. So maybe this is a golden time to try them or to utilize them if you have them in your clinical service. If you have the ratio of the SFLIT versus PLGF, if it's less than 38, then the negative predictive value, which means to rule out preeclampsia within a week, is extremely, extremely good. So if you see a patient like this, and then you just do your ratio and it's normal, then you can reassure the patient and send her home. She does not really need to be admitted. On the other hand, if it's high, then the positive predictive value is not as great. But if it's really, really high, then the positive predictive value, this is what I'm talking about, the positive predictive value for a delivery within the next 2 days is going to be extremely high. So therefore, utilize the tests that you have, if you do actually have them, for the benefit of your patients. So it's a good predictor, and elevated ratios are associated with increased risk of actually developing preeclampsia, and specifically developing early onset preeclampsia. So what other things we need to remember? Remember, women are staying at home. They're really not as active as they used to be. So therefore, whenever you have a patient that might be at increased risk of venous thromboembolism, then you really have to give her the advice about hydration, about mobility, limited exercise that she can do at home. And sometimes you might even want to consider giving thromboprophylaxis for a specific, criteria or a category of your patients. How about diabetes? Obviously, diabetes is quite common in our population, and you are likely to face a lot of pre-existing diabetic mothers. They are more vulnerable to COVID-19, so therefore, maybe you want to avoid bringing them to the hospital very frequently, but on the other hand, you need to bring them again for the needed tests. Like I mentioned earlier, in the first trimester, you give them advice about their blood sugar control, their blood pressure monitoring, if she has other comorbidities with the diabetes, and so on. And definitely retinal screening might actually be required, although I know that some other specialties might not be working as much nowadays, but if the patient needs to have a retinal test, then she needs to have it. And then minimal follow-up will be at 28 weeks, at 32 weeks, just if we can do it face-to-face, otherwise it could be teleconference, or and later on 34 to 36 weeks to do repeated ultrasounds for growth, and then to decide the timing of birth. This is a nice workflow that I saw from one of the recommended guidelines from the UK, and basically it just tells you that, I mean, having the mothers involved in their own care is extremely important, and they need to be aware of the blood glucose monitoring, and they need to communicate with you with regards to their diabetic control. And if it's not controlled, if you have more than 3 readings that are out of control within a week, then maybe we need to consult them, to counsel them with regards to the medications they need to use. If she needs to have insulin, then maybe you need to bring her back to the hospital, or arrange, you know, some sort of education, maybe educational video or something like that. You know, just be innovative, be consider, you know, other ways of doing things rather than the classical ways that we have been doing them. Renal disorders, again, are quite common in our practice, and they are at particularly high risk of having problems and complications, especially if they are stage 4 to 5, which usually at this stage they might be like on dialysis. And again, you need to instruct these women to have more blood pressure control at home, and just see them whenever you need to. So in the first trimester, then see them again at around 20 weeks. You might need to see them a bit more frequently to do like serial ultrasounds for growth. Even blood work, although she doesn't really need to come to the hospital. Maybe if your hospital has like a satellite lab or something where she can have the blood test done, and then you can always check the results and consult the patient on phone. Again, remember, whenever you have a patient coming to your antenatal care, there's always a triage that should be conducted, and I'm sure this is what all the hospitals are doing at the time being. So there's a triage with regards to the symptoms that could be suggested for suggesting COVID. If the patient has no symptoms, then obviously she can go ahead and enter into the clinic visit and be evaluated by your team. If there are some symptoms, then obviously you have to make sure that the patient has the appropriate mask. And depending on the symptoms that she's complaining with, if they are like purely obstetric related, then obviously you need to take care of her in an obstetric related area. Even she might be transferred to the labor room. If they are non-obstetric related, try to avoid entering the patient into an obstetric area just to avoid the risk of exposure to other women, and try to triage her away from your labor room, from your antenatal floor. And then depending on the category that she has, if she is like high risk, then obviously you need to involve other specialties with your care. If she is lower risk and she can be managed at home, then maybe she can go home, be in self-isolation, and come back to the hospital whenever there's an obstetric complaint or wherever she is out of the isolation. Again, this is a flow sheet that is from the Society of Maternal Fetal Medicine. And again, it just gives you very similar, like workflow, where you assess the patient depending on their risk categories, and then you decide whether they're low risk, intermediate risk, or high risk. Just few words about how to care for women if they are suspected or confirmed COVID-19 if they come to labor. I'm sure most of the hospitals already have like workflow for dealing with these patients. Obviously, they need to be admitted to an isolation room, ideally in a negative pressure room. If you don't have a negative pressure room, then there is filters, HEPA filters, where you can put inside your rooms, and it sort of converts it into a negative pressure room. You need to do full evaluation of the maternal and the fetal condition. You make sure that all your multidisciplinary team are involved in the care. We manage labor as like a standard practice, but obviously depending on the risk categories that the patient has, and if she actually is symptomatic from the COVID, then obviously the management is going to be a bit different. It doesn't seem to be there's a preferred mode of delivery, and normal delivery could be considered definitely with delaying rupturing of the membranes. And but sometimes, obviously, if the patient is a bit more sick, she might not be able to pass through a normal delivery. Then in these cases, we might need to consider a cesarean section. Epidural analgesia should be recommended quite early in labor. This is just to minimize the chances that the patient might need an urgent delivery. And obviously, general anesthesia is associated with an increased risk of a viral spread, and therefore it's better to avoid as much as we can. If we have to go through a general anesthesia, then there's a lot of guidelines that are utilized by the anesthesiologist during the period of the COVID. There was some talks about the Entonox and the Entonox being a route of actually increasing the spread of the virus. But if there are like specific valves that can actually reduce the spread of the Entonox outside, it can be utilized. Although, I mean, us in our King Faisal Specialist Hospital, we decided not to use Entonox during this period, since there is some concern with the use of the Entonox. Maybe it's not a bad practice to shorten the length of the second stage, just to, especially if the patient is symptomatic, and other practices such as delayed cord clamping can still be utilized. And make sure that the room should be disinfected after the patient is discharged. The placenta should be kept in a specific container that should be washed and labeled that the patient is suspected or COVID. And as per the MOH guidelines, the relatives should not be allowed into the labor room. And I'm sure a lot of you are facing the same problems that you are facing in the hospital, where relatives, want to be in the delivery room. And if you go by the UK guidelines, they actually advise that one relative who is definitely negative or is asymptomatic should be allowed, because that definitely improves the outcome of the delivery itself. But we actually took the notion of not allowing anybody to be with the woman in the labor room. So a few discussion points that I wanted to bring up. Do we practice universal masking to all or not? And there's a lot of recent recommendation that universal masking is actually a good practice. Definitely your staff needs to be wearing the masks. I mean, it doesn't need to be the N95 masks unless the patient is actually known to be COVID positive. But just for the normal practice in the hospitals, it's a good practice to actually be wearing masks during this period till we get different recommendations. And to screen or not to screen women coming to your antenatal clinics and to your labor room. I mean, obviously, it might not be that easy to screen by swabs for women who are actually just coming to the antenatal clinic, but definitely for women who are being admitted to the floor, there's a big, recommendation to actually screen them. And till the results of the screen are out, you need to consider them as being potentially positive, and therefore, activate your COVID protocol if you have one, or you need to develop one. And till you get the results back. And definitely if they are positive, then they need to continue through the COVID protocol. If they are negative, then you can just treat them like normal patients. I mean, people might have the concern that, well, I mean, the results might take a few days to come back, and this is definitely a concern. But if you try to make your life more organized, if you maybe it's a time to consider more elective like inductions rather than just letting them come unscreened. So whatever it takes, to make yourself and your staff and the other patients safe is a good time to practice at this stage. So this is the end of the first lecture. This is actually a frontliner, my son, Abdulaziz. He is actually practicing in New York. He's a surgical resident, but at the time being, he's in charge of an ICU unit in one of the very, very busy New York hospitals who's actually dealing with COVID. So once in a while, we have to be frontliners, and we just have to deal with whatever comes to us, and we try to plan our lives accordingly. Don't forget that you still need to give care to other women. Don't let Corona take over our lives. So we have to provide care for other women who are Corona negative and potentially might have more risks and more complications, more than actually being exposed to the Corona. So this is the first lecture, Samer. Do I continue? Well, take questions. Well, what do you want me to do?
Yes, Doctora, you can continue for the next lecture, and we will keep the question till the end of both lectures.
Okay. So the next lecture is, we thought, since we are in an era where there are infections, and infections potentially can cause fetal abnormalities. So we thought of actually talking about reducing the risk of fetal anomalies and what is our role as obstetricians in that. So as per the WHO definition, a birth defect or a congenital anomaly is any structural, functional, biochemical, or molecular defect that is present at birth, whether it is actually detected at birth or not. So it might be present at birth, but it might not be detected later on, even in adulthood, but it's still considered as a birth defect or a congenital anomaly. The most common ones that we actually see are the structural abnormalities. Major congenital anomalies are present in up to 2 to 2.5% of all deliveries. They are present in 1.6 of our life percentages in stillbirth, because a lot of anomalies are actually incompatible with life, and therefore they are present more in stillbirth, in neonatal deaths, and in infant deaths. Why are they important? Because a lot of them die in the neonatal period. A good proportion of them might be mentally abnormal, and only like 50% of them might actually have fair prognosis after treatment. So our role is actually to try to identify them and to maybe prevent their occurrence. Congenital anomalies, etiology of congenital anomalies could be either genetic, which involves both So if we talk about genetic could be chromosomal, Down syndrome, for example. It could be Mendelian or single gene disorders, like all the single gene disorders that we see in our life, like skeletal abnormalities, like a lot of metabolic disorders, a lot of blood disorders, and so on. And the two most important contributors to increasing risk of genetic diseases will be advanced maternal age and consanguinity. And obviously, consanguinity is something extremely important in our environment, in our culture. Environmental, like infections, like maternal diseases, diabetes, teratogenic exposures like alcohol, smoking, or even environmental exposure. And multifactorial, which is the most common, like 60–65% of all anomalies that we see are multifactorial, where there's really a predisposition that is already present, but this will be triggered by the environment. And this includes most of the abnormalities that we see, such as neural tube defects, a lot of cardiac abnormalities, hip dislocation, hypospadias, and so on. If we consider the congenital malformations at the time of birth, then you'll see that the risk is something like 2 to 2.5. But if you consider it during all the way up to adulthood, you will know that maybe up to 15% of the population might actually have congenital malformations, because there's a lot of diseases that will not show up till later on in life. Excuse me, Ramadan وصايمين بقى ونبح الصوت. Sorry. So what is our role as obstetricians? Excuse me. We can practice primary prevention, secondary prevention, or tertiary prevention. Obviously, each one of these have their own implications and areas where we can actually practice them. So primary prevention is to prevent the disease from occurring. For example, we give rubella vaccine to prevent that the mother contacts rubella, and therefore the baby will develop congenital rubella syndrome. This is primary prevention. If we give it, the mother will not have congenital rubella syndrome. We can do primary prevention by giving preconceptional folic acid supplementation, for example, to reduce the risk of neural tube defect. Secondary prevention is by early detection of the abnormality, and then maybe either offer a treatment or even termination of pregnancy can be considered as secondary prevention. And tertiary prevention is by surgical intervention, for example, or medical intervention early, which might reduce the residual effect of the disease. It will not totally remove the disease. So what are the different areas of congenital anomalies that we actually face in clinical practice? There are neural tube defects, there are fetal diseases like infections, toxoplasmosis, genetic diseases such as cystic fibrosis, growth restriction, and other disabilities that we might face. We'll start off by talking about the neural tube defects. The EuroCAT, which is the European Surveillance of Congenital Anomaly, is a population-based registry that actually collects all the cases of neural tube defect that are reported, or structural abnormalities, including the neural tube defect. And in their data, they said that the rate of neural tube defect is around 9 per 10,000, which is around 1 in 1,000. So that's something common. So we need to find ways of actually reducing the risk of neural tube defects. And we know that the neural tube is around the 28th day of after fertilization, the cells of the neural tube will actually develop, and it will have the folding at that stage, and the development of the neural tube will be completed. And the studies have shown that deficiencies of maternal folic acid at that stage will lead to abnormalities in this folding process and in the complete closure of the neural tube defect. So, and studies have shown that if you actually take folic acid supplementation, you'll be able to reduce the risk of neural tube defects to a great extent. But remember, I just started off by saying by the 28th day after fertilization. So which means that we are at, week 5 or week 6. And a lot of women don't actually even know that they are pregnant at that stage. So a lot of women have totally irregular menstrual cycles. Only 50% of your population will have an optimal LMP. And even with the optimal LMP, it could be, excuse me, it went on. Okay, even with an optimal LMP, it might actually be irregular cycles. So you'll be facing a lot of women who might not actually even know that they are pregnant by the 5 or the 6 weeks after conception. And how about planned pregnancy? I found this is quite interesting that in Hungary, they found that the proportion of pregnancies that are planned at different ages, the maximum is something like 60–70%. So the majority of pregnancies are really unplanned. And in other European countries, the maximum of planned pregnancy is only 86%. And there are figures as low as 20 and 30%. And I really don't have figures here in our country, but from our practice, I'm sure that at least 50% of your pregnancies are not going to be planned. And therefore, you need to do something about it. You need to actually offer women folic acid by different means. Studies have shown that if you actually give 4 milligrams of folic acid in the preconceptional period, then you will reduce the risk by up to 70%. Other studies have shown that you give a dose of 0.8, then you'll also reduce the risk of neural tube defects by a good percentage. And remember that preconceptional means at least 1 month before the last menstrual period until the end of the first trimester. So it's a good 4 to 5 months period to actually do that prevention or reduction in the rate. Is the prevention of neural tube defect dose related? Some studies have shown that if you actually give the 0.4 or the 0.8, you will reduce the risk by around 36%. But if you give 4 to 5 milligrams, then you will reduce the risk by up to 85%. There are other benefits of folic acid supplementation, not only for the neural tube defects. Studies have shown that you reduce the risk of oral clefts. You might reduce the risk of congenital cardiac defects, urinary tract abnormalities, rim reduction defects on phalloceles, anal atresia. And remember, we just mentioned that there is a good proportion of people who are born with birth defects. And even if we reduce them by 15 to 20%, that's a major, will have a major impact on your population. Other benefits have been, also shown in other studies. They have higher birth weight. Even there's a reduction in the risk of pediatric cancers like leukemias, brain tumors, Wilms tumors, and neuroblastomas, and even a reduction in the risk of severe language delay and autism. So folic acid seems to be something good that we should advise women to utilize in the preconception period. Who should be receiving a higher dose of folic acid? Obviously, people with a previous neural tube defect should not be using the normal 0.4 to 0.8. They should be receiving a dose of at least 4 to 5 milligrams daily. Epileptic mothers on anti-epileptic medications, they need higher doses. Diabetic mothers, obese mothers, and women who are using alcohol, tobacco, and other recreational drugs. Okay, we know folic acid is important. We know that we should be using folic acid, but how much is that information actually cascaded down into our women? This is, study from different countries in Europe, and women who actually utilizes folic acid properly in the periconception period, like what we mentioned earlier, preconception, and during the first 3 months, maximum was only 40%. So really, we have a very great area of actually for improvement. There's still up to 80% of some populations they have not actually even know that they should be using folic acid, and this is really not very good news. How about us here in Saudi Arabia? We actually have a neural tube defect registry in our hospital at King Faisal Specialist Hospital, and this is one of the papers that was published from this registry. And there was over 700 patients, and out of these women, again, I mean, not all of them were unfortunately diagnosed during pregnancy. Only 63% were diagnosed after birth. So even the diagnosis is not very great. But more importantly, what I wanted to stress on is that the preconceptional use of folic acid on an yes, it was only 7%. On and off was was only 1%, sorry, and on and off was only on 4%. And during the first trimester, so once they actually start coming. Once they actually start coming to see us, we tell them that they have to be on folic acid, and they start using it. But that is unfortunately a bit too late. Already the neural tube has already developed, so it's not really good. So we still have a long way to go. There was another study that we actually conducted at our hospital, just to know how much women actually are aware of the need for using folic acid. And again, I mean, the data was, the majority knew that they have to use folic acid, but only like half of them would actually use it in the periconceptional period. So we still have a long way to actually educate our population, or again, consider, utilizing folic acid by other means. Diabetes is a very important pregnancy complication, and the data in our country says that maybe at least 30% of women are actually diabetic or potentially diabetic, and this even increases in pregnancy, especially mothers who have a pre-existing diabetes, specifically type 1 diabetes, but even type 2 diabetics who are poorly controlled, then they are at increased risk of having a lot of malformations, including congenital heart diseases, neural tube defects, sacral agenesis, femoral hypoplasia, holoprosencephaly, and seronemelia. And this is definitely related to the control of the diabetes. If you have very well-controlled diabetes with a good hemoglobin A1C, then the risk of these malformations will be very low as 3%, while if you have a hemoglobin A1C, which is really, really high, then more than 14, then the risk of these abnormalities might increase all the way up to 40%. So this is a very important area for us to actually consider. Care of the diabetic mothers in the preconception period. Make sure that they only enter pregnancy after they have achieved a very good diabetic control. Limiting exposure to teratogen is something very important, and that we should have a say in it. We should make sure that we educate our women to avoid alcohol, to avoid cigarette smoking, and definitely these have a very good association with fetal structural abnormalities. Smoking is associated with increased risk of stillbirth, low birth weight, cleft lip and palate, and alcohol is associated with a lot of abnormalities, facial abnormalities, or congenital alcohol syndrome. Medications like anticonvulsants, what we were mentioning before, if patients are on specific anticonvulsant medications, such as the older medications like carbamazepine, phenytoin, these are associated with increased risk of congenital abnormalities, specifically cleft lip, cleft palate, heart defects, and spina bifida. And therefore, again, the preconception care of these women is extremely important in order to actually make sure that they are well controlled from the epilepsy point of view, and that they are using more safe medications, and ideally the lower dose, and ideally one medication before they can actually start a pregnancy. Some other medications that might be potentially teratogenic includes ACE inhibitors, and therefore it's very important for women who are hypertensive, if they're considering pregnancy, to change them to other medications, lithium, phenytoin, retinoids, and we see a lot of women who are utilizing retinoids for skin conditions. We have to make sure that they're using the appropriate contraception while they're using these medications to avoid the risk of exposure in early pregnancy. And warfarin also is an important medication that we face once in a while. Infections, since we're in the era of coronavirus, one of the important infections that are very important to actually avoid contacting in pregnancy, and therefore we have to practice vaccination, is rubella. And this is one of the important vaccines that that children will receive in childhood. And again, adolescent, they will have usually a booster rubella vaccination. And now in the premarital period, women are actually screened for infections. So rubella immunity should be included in that. And if she's non-immune, then we need to offer her the rubella vaccine. Ionizing radiation, sometimes once in a while, for whatever reason, the woman could be exposed to ionizing radiation. Obviously, it's very important to instruct women to tell if they are pregnant or expecting to be pregnant, or they have irregular cycles, or even simply that they are not on contraception. Then the risk of pregnancy can always be there. And if it happens that she's exposed to radiation, then we can calculate the dose, and depending on the dose that she was exposed to, we can decide whether this is a high dose or a low dose. So 70% of our birth defects are preventable, and it's our role to actually try to prevent them. And like what we said earlier, prevention could be primary, secondary, or tertiary. Primary, the important things that we talk about is preconception and premarital, and these are extremely important. Secondary is screening and testing and management, and tertiary is the surgical intervention or medical intervention as needed. The four most serious and prevalent congenital disorders are the hemoglobinopathies, and we screen for these in the pre-marital period. Screening for Down syndrome is extremely important. Neural tube defect screening and prevention is extremely important, and congenital heart defects. And again, one of the important people who might be exposed to a higher risk of that is our diabetes control and epileptic mothers who might be potentially on medications that might increase the risk of congenital heart defects. So if we speak about premarital counseling, in addition to screening for infections and vaccination and hemoglobinopathies, which is a requirement in our country, it's extremely important to actually be able to do targeted screening. So look for family history, look for any genetic diseases that are present in the family. And if we know that there's a specific family history of a specific genetic disease, then we need to do targeted screening for that specific disease. I mean, there's really no point screening for sickle cell anemia where there is nothing in the family, while on the other hand, the family has a very strong history of propionic acidemia, for example. So it's really more important to screen the couple for propionic acidemia, and if they happen to be carriers, and they still decided to go on with the marriage, then reproductive options should be discussed with them at an early stage, maybe before the marriage or the early stages of marriage, and give them options of a pre-implantation genetic diagnosis or prenatal diagnosis, which is sort of like a secondary prevention rather than a primary prevention. But again, it is prevention. How about the preconception? Like what I've mentioned earlier, we look for any pre-existing medical diseases like diabetes, like heart defects, for example, where the mother is on anticoagulation like warfarin, epilepsy, renal, where she's on medications. We make sure that she is well controlled with respect to the disease itself, and that we are shifting her from medications that are potentially teratogenic to medications that are potentially safe. in pregnancy. We advise them about a healthy lifestyle, avoid overweight, make sure that minimize exposure to teratogens and alcohol and smoking and so on, and for healthy life, and definitely in the periconceptional period. These are some of...
Dr. Wissam, you are exceeding the time. Can you finalize it?
This is the last slide, Wallah, I promise you. So these are basically the identified interventions that are known to improve the pregnancy outcome. And these are basically the things we just mentioned: folic acid, rubella vaccination, obesity control, infections, avoiding infections and treating infections, smoking cessation, and so on. Thank you.
Thank you, Dr. Wissam, for both interesting lecture. I would like to ask you, what is your advice for our patients in the pre-pregnancy clinic concerning the neural tube defect?
Yeah. I mean, we need, it's not only the preconception or the premarital, this should be like public awareness. There should be public awareness that women need to use folic acid in the periconceptional period. So if she is a very organized, a planned, a person that can actually plan her life, she would know when she's going to get pregnant, then it's enough to start it like a couple of months before the pregnancy. The problem is that, like we just mentioned, a lot of pregnancies are unplanned. So, I mean, the choice would be either to utilize, folic acid all the time as part of multivitamins, or even folic acid, alone during the periconceptional, during the reproductive years of the woman's life, or even utilize, contraceptions that are available nowadays that actually have folic acid with them, like YAS. You're going to be hearing, a few things about YAS Plus at the end of today's symposium. So this is a very intelligent step, actually, to have folic acid already added to a contraception that the woman is already utilizing. So therefore, at the minute that she stops the contraception, she can go ahead and get pregnant because she's already utilizing the folic acid. So that might actually be a thing to advertise for.
Thank you, Dr. Wissam, for your interesting lecture. We will move for our next speaker, Dr. Karima Salama. She is a consultant in gynecology and minimal invasive surgery. She is a consultant in My Clinic International Medical Complex in Jeddah, Saudi Arabia. In the next 30 minutes, she will speak about the hormonal intrauterine device beyond contraception and about the dysmenorrhea. It's all yours, دكتورة كريمة. تفضلي. أهلا وسهلا.
السلام عليكم. كل عام وانتم بخير, and thank you for the nice, for the good invitation to start to talk about some common gynecological problem. I would like you to apologize me because it's the first time to use this technology in order to go for lecture, but we'll try to do my best. Anyhow, so here we go. So I'll start maybe to first to talk about dysmenorrhea, and it's a kind of a common problem we are facing in the clinic every day, properly, as well as in the common practice in the family medicine and other general ER visits for patients coming through the ER complaining of severe pain during their menstrual period. I'll come across the definition of dysmenorrhea with the classical terminology of primary and secondary, and then we'll go through the epidemiology, mechanism, and clinical manifestation, evaluation, differential diagnosis, the treatment, and finally the recommendation. So when it comes to the definition, we all know that dysmenorrhea is defined as a pain associated with menstruation. And the term dysmenorrhea is derived from a Greek word, which is dys, means difficult. Menorrhea means monthly flow. When we see the incidence, the pain is a subjective symptom. So we cannot find the estimated risk, the estimated incidence of having patient with dysmenorrhea or experience this kind of pain is ranging between 50 to 70. So it's quite high. And 10% is implicated by implicating on their usual activity. When it comes to the primary, that the symptoms essential, which is an interesting and functional, and is defined as a painful menstruation in the absence of pelvic pathology. So when we talk about, or if this is just a brainstorming idea, when we talk about the dysmenorrhea, whether it's a primary and secondary, it's quite difficult to say it is a frank primary dysmenorrhea, and it's quite difficult also to say it's a frank secondary dysmenorrhea, because we need to rule out pelvic pathology. So pelvic pathology cannot be ruled out from the first presentation, because it's unfair to expose the patient of any invasive procedures in order to find out pelvic pathology, which is the most commonest and the most dilemmatic actually subject, which is the endometriosis, where Dr. Samir Sindi gonna come across it. He's an expert in that field. But so let's consider all dysmenorrhea are primary till proved otherwise. So the pain of the primary is typically coming prior to the menstruation in the first few days, and is typically eliminated with the flow of the menstrual cycle. When we say that the epidemiology is quite ranging between 60 to 90% for the prevalence of dysmenorrhea among adolescents female, who are the most common group, and 15% of female seeking medical advice for that. And many adolescents get the dysmenorrhea in their interfering with their daily activity and school attendance and sport event and other social activities, which impact their psychological performance. The dysmenorrhea generally does not occur until the ovulation menstrual cycle established, so which occur from the month of several years after menarche, depending on the individual rate of menstruation and hypothalamic pituitary gonadal axis. So 18 to 45%, they have experienced dysmenorrhea in around the first 2 years after menarche, where 45 to 70% in the 2 to 4 years, 80% by the 5 years. This is the approximate time of ovulation ovulation to happen after menarche. So when it comes to adolescent to the clinic complaining of dysmenorrhea at the beginning of her menarche, most probably we should not consider it as a primary dysmenorrhea, because we know that they are not yet at the level of considering them ovulatory cycles, since 18 to 45% they start ovulation after 2 years. This is the dysrhythmic uterine contraction happening, and the hypercontractility and increase in the secretion of the prostaglandin in the uterine muscle tone, leading to the uterine ischemia due to excessive production of the prostaglandin, whether F2 alpha or PGE2, and that what believed to be the main reason and the mechanism of the occurrence of dysmenorrhea. There are various theories for the etiology as well, which is one of them, the prostaglandin theory, as I mentioned, which is the most widely accepted theory. And there is 3 main prostaglandin occurred with the menstruation, which is prostaglandin F2 alpha, prostaglandin E2, and BGI2 as well. The main effect of the prostaglandin dysmenorrhea, they are potent vasoconstrictor and cause an increase in the myometrial contractility. E2 is increase the sensitivity of the nerve ending, and PG12, which is a vasodilator that decreased prior to the menstruation, leading to ischemia. So all these physiological actions definitely will need to increase the severity of the pain, and will be the most potent theory, the most reliable theory in the occurrence of dysmenorrhea. We know that all those prostaglandin times are high in quantities in the menstrual flow, in the menstrual fluid, which is proved by biochemical testing. And the evidence to support this theory, which is the prostaglandin synthetase inhibitor, are found to be relieving the symptoms of dysmenorrhea and decrease the menstrual fluid prostaglandin concentration and decrease the uterine contractility. That's why we will see later it becomes one of the first line management of the dysmenorrhea. The second theory, which is the hormonal or endocrine theory, dysmenorrhea is characteristically seen in the ovulatory cycle, where the prostaglandin play a key role in the evidence in the happening of the dysmenorrhea. And the evidence to support the theory is seen in the following factors: is an anovulatory cycle are usually painless, and that is why the primary dysmenorrhea starts 1 to 2 years after menarche. When we talk about prostaglandin concentration is higher also in the secretory phase, that's also more supportive for the this theory. But all the theories is just like turning around the presence and the flow of the prostaglandin in the menstrual flow. The myometrial contractility, which is also a result of the high flow prostaglandin, there is usually hyperactivity in the time of the menses of the myometrial contraction, puts the stretch on the uterine nerve fiber ending, thus causing the pain. Myometrial ischemia also as an end result of the increasing the prostaglandin P12, which is in the normal menstrual cycle, there is a vasodilatation during the secretory phase, which increased the tortuosity of the spiral arteries. Just prior to the menses, the spiral arteries undergo vasoconstriction, and the decrease in the uterine blood flow caused an ischemia. Ischemia is a known cause of pain, and thus this theory maybe compares dysmenorrhea to the pain of angina. Uterine abnormalities, patient with known cervical obstructions in the earlier years, cervical stenosis was believed to be a single most important cause of dysmenorrhea. So always put this in mind if an adolescent come to your clinic shortly after her menarche complaining of severe pain, think about uterine abnormalities, because we know she's not yet at the level of having regular ovulatory cycles, so maybe a congenital anomalies can be a reasons. Uterine abnormalities can be a redundant uterine whore or imperforated hymen. Of course, we know that not a complete imperforated hymen, because at the same time, if she's not having any period after that, you can directly think about imperforated hymen, especially if it is associated with kind of abdominal swelling, or and that of course will be supported later by some radiological pictures. Psychological. Though dysmenorrhea is proven to be a physiological disorder, but physiological factors modify the pain or its intensity rather than causing it. So please don't consider everything when your child comes to say that I have severe pain. Don't tell her that انت just بتدلعي or something like this. No, because we know if she's not having the pain, she will not complain. Properly, the psychological factors will modify the pain or will make it more exaggerated, but it's not the cause of the pain. All of the above, usually the right answer when we have an MCQ question. So this is the actual theory of dysmenorrhea, where the pain is the result of a concurrent occurrence of two or more factors. So it's not only a single factor. So we cannot say that it's only because of the prostaglandin increase, or it's only because of the hormonal, or it's only because of the psychological. Of course, congenital anomaly has special circumstances, but usually all is a combined factors that ended with the appearance with the complaint of the dysmenorrhea. The progesterone withdrawal will alter the prostaglandin, which alter the myometrial contractility, and thus the pain will occur. The psychological factors maybe play a part in all of the above as well. Let's look at the risk factors of the primary dysmenorrhea. Well, menstrual factors, early menarche, long and heavy menstrual flow, and parity, the incidence of dysmenorrhea is usually lower in patients labeled as multiparous women. Always we think about diet. Low consumption of fish, egg, and fruits are believed to be increase the incidence of dysmenorrhea. Exercise always seen that among athletes and incidence of dysmenorrhea was lower, properly due to the anovulatory cycle. So when it comes to cigarette smoking, heavy smoking was found to be associated with the increased duration of dysmenorrhea, and psychological, emotional dependent and overprotected girls are most likely to develop dysmenorrhea. Maybe this is like a psychological rebound for the adolescents to get rid of their family control. They always complain of pain in order to just bring their attention. It's also more commonly seen in the girls whose mothers suffered from dysmenorrhea, which thereby make the younger more conscious, like mom, like the daughter, and they make them more conscious and more aware about the panorrhea and her coming menses. Rather than being a cause of the pain, is more likely to be a psychological factor that modify the pain, as I said before, and causing the depression and anxiety. The pathogenesis, I keep repeating, the pain pathway of dysmenorrhea is following the sympathetic fibers. pass from the uterus through the posterior route of T10, 12, and T11 and 12 and L1, from the cervix through the S2, S3, and S4. Thus, the uterine pain is referred to the cutaneous distribution of the lower abdominal wall in front, and the groin and the upper medial aspect of the thigh, nearly to the knee, and posterior to the sacral area and buttocks, while that from the cervix to the lower sacral area and the buttocks. Clinical manifestation, simply the patient we start always with history, where the patient, we have to evaluate her menstrual history, assessing the age of menarche, duration of the menstrual bleeding, the amount of the flow, interval between the menstrual bleeding to evaluate whether it's regular or not, first day of the last 2 menstrual period, and the symptoms, and the symptoms history, of course, when it starts and how it's alleviated. We need to ask about the patient age, and usually the dysmenorrhea seen among the younger women, and time and onset 2 to 3 years after menarche, where the period become more ovulatory. Duration of pain is always started prior to the menses and lasting for 2 days. The type of the pain always cramping and above the described area, as I mentioned, according to the nerve distribution. Generally, abdominal exam usually normal, and local exam essentially normal pelvic organ. So the severity and disorder can be categorized by grading system based upon the degree of menstrual pain, presence of systemic symptoms, and impact on daily activity. Also, sexual history, current sexual activities, and time of contraception used, the history of sexual transmitted infection, and history of pelvic inflammatory disease. And don't be surprised when I talk about dysmenorrhea in adolescence, and we should not come across all these points. No, we should evaluate the patient regardless of the society and the culture boundaries, because we start to see some of sexually transmitted disease among young generation. The initial onset of the symptoms and progression over time, we need to evaluate the relation of the symptoms to the period. We need to evaluate the presence and absence of nausea, vomiting, as I mentioned, the systemic symptoms, diarrhea, back pain, dizziness, fatigue, and headache during menstruation, impact of the symptoms on daily activities such as school attendance, sport activities, and other social activities. The medication patient started to use, which is the type, dose, timing in relation to the onset of the cramps and previous effectiveness in terms of pain relief and ability to engage in daily activities. So when it comes to the grading system, according to the American College of Obstetrics and Gynecology, they put a severity at a grading from grade 0 to grade 3, according to the working ability and systemic symptoms and analgesia required, as we can see it here, from grade 0, where the menstruation is not painful and daily activity is unaffected. Usually her working ability is unaffected and the systemic symptoms is not present and analgesia not required. So these are only grade 0. So when it comes only to mild pain, so we can figure out with your daughter is spoiled or not by looking at this page, and it's very easy even to be interpreted by population, not necessary to be a medical in medical field. While we compare to grade 3, where the patient is severe, pain, activity is clearly inhibited and poor effect of the analgesia. Patient become having some vegetative symptoms like headache, fatigue, vomiting, diarrhea, and patient really in severe pain. She started to, that will start to affect her working ability, and systemic symptoms always appear, and there is no almost or poor effect of the analgesia. So this is clearly indicated that there is a severe pain and this patient is really honest. So evaluation, as I mentioned, by looking at the table in the previous slides, where we can find out, usually, as I said, the abdominal exam is not that specific or unremarkable unless the patient presented in the early onset of her menarche with a severe pain, where we start to think about congenital uterine anomalies, commonly in perforated hymen, where we could feel pelvic mass, or sometimes when it is very severe or distant, hugely distended, started to be a pelvic abdominal mass. That gives us a clue of possibility of imperforated hymen, especially if the patient is saying that she's having a pain, but she doesn't have a measurable amount of blood flow from the uterus. So physical exam, as I said, usually is specific, and it's not, of course, when it is to come to the clinical exam, but when it comes to the pelvic ultrasound, it should be performed if patient, as I mentioned, suspecting congenital anomalies. Patient with sexually transmitted disease or with pelvic inflammatory disease, usually we could see the typical picture, the typical findings on examination of having cervical excitation or adnexal tenderness or palpable mass in the adnexum. Coming to the differential diagnosis, as I said, always think about anatomical abnormalities in special category of the patient, where history of painful menses coming in at the onset of menarche, and possible cause of incomplete penetration of the hymen. Psychogenic contribution, usually complete psychological history, may suggest other causes of abdominal pain like depression, substance abuse, stress secondary or abuse, or trauma. Endometriosis, I'm not gonna come in details because Dr. Cindy gonna give us a full lecture about it. So, but shortly, menstrual pain that become progressively worse over time is very characteristic for endometriosis. And that might present as a cyclic pain or non-cyclic pain. Endometriosis is a common cause of secondary dysmenorrhea. Probably it's the only cause. Pelvic examination may reveal a tender in a cul-de-sac or uterine signal, uterosacral ligament nodularity. Pelvic inflammatory disease, also adolescents who have pelvic inflammatory disease, as I said, they have typical findings of cervical excitation or cervical motion pain, adnexal tenderness and bimanual exam, or sometimes palpable pelvic masses. Coming to the treatment, the severity of menstrual pain and limitation of daily activities will help to guide the treatment decision. General measures for therapy include patient reassurance, education about options for medication and their appropriate use after reaching the proper diagnosis. We always start with NSAIDs, non-steroidal anti-inflammatory drugs, for patients who do not desire contraception. NSAIDs, anti-inflammatory medication, is considered the first-line therapy, and also is a good adjuvant for the patient who choose hormonal contraception. A randomized trial of NSAID, approximately 70 to 90% of patients who have effective pain relief, and value that is greater than with placebo. Hormonal therapy or contraception are appropriate as a secondary line therapy for patients who are not sexually active, but who fail to respond to or cannot tolerate NSAIDs. First line therapy in patients who are sexually active also, because they prevent both dysmenorrhea and pregnancy. Others, like including a transdermal patch or vaginal ring or injectable or implant contraception or levonorgestrel releasing intrauterine device, may also be effective in the treatment. Amenorrhea induced by any means of is beneficial for the treatment of dysmenorrhea. Like, of course, hysterectomy is the most effective treatment, and there is some evidence to support laparoscopic nerve ablation in selected cases. Endometrial ablation is likely to reduce the symptoms of dysmenorrhea when it occurs in the presence of amenorrhea. So in summary, the management of dysmenorrhea in selected base of severity of dysmenorrhea, usually we go with general measures and specific measures. The specific general measures will come across in a while, but the specific measures either medical or surgical. Surgical has to be the final end result for patients who failed all kinds of treatment, and most likely they are because of secondary pathological pelvic pathology, most commonly endometriosis. So when it comes to the medical, as we said, for patients who are desiring hormonal therapy, we can use either oral, transdermal, injectable, IUDs. Non-hormonal NSAIDs is the first-line therapy for both categories and for most adolescent patients. The recent advance in the management of dysmenorrhea, laser parasacral neurotomy, lysine cloexetine for the treatment of primary dysmenorrhea. This is a newer NSAID given in a dose of 125 milligram tablets 4 times a day. It acts like an analgesic and antispasmodic. Sublingual piroxicam is a fast and dissolving form of tablets being used in the minimum side and good efficacy. Transdermal glyceryl trinitrate acts for relieving my mitral contraction and thus acts as in a trine relaxant. Rifoxicam is a specific cycloogenase 2 inhibitor in a dose of 25 to 50 milligram every 24 hours to inhibit prostaglandin synthesis. General recommendation, both primary and secondary dysmenorrhea are likely to respond to the same medical therapy. Therefore, initial treatment should not depend on establishing the precise diagnosis. So don't waste time and leave the patient to suffer. Please start the diagnosis and start the treatment and leave the diagnosis for the response versus failure. Healthcare providers should include specific questions regarding the menstrual pain when obtaining a woman's medical history, as I mentioned earlier, and the pelvic exam is not necessary for the prior initiation of the therapy. Pelvic examination is indicated in patients not responding to conventional therapy and when organic pathology is suspected. NSAIDs, anti-inflammatory drugs, and administered with regular dosing regimen should be considered the first-line treatment for most women, especially adolescents. Hormonal therapy should be offered for women and girls who are not currently planning pregnancy unless contraindication exists, and that comes also with proper evaluation in history. Continuous or extended use of combined hormonal contraceptive are recommended, and please assure the moms and the girls when they start to use, they are not going to be infertile. Regular exercise is likely to improve the symptoms for dysmenorrhea and should be recommended. Local heat is the form of heat pad or patches, gerba, should be recommended as a complementary treatment for dysmenorrhea, and it is highly effective, as we can see the evidence. High frequency transcutaneous electrical nerve stimulation should be considered as complementary treatment or in women unable to unwillingly use of conventional therapy mentioned earlier. Acupoint stimulation should be considered for women wishing to use the complementary or alternative therapies. Ginger is a good and it's highly recommended for women wishing to use a complementary alternative therapy. Preoperative investigation should include a detailed history of physical examination, ultrasound, and possible magnetic resonance imaging to discover secondary cause of dysmenorrhea and to direct appropriate therapy, especially if we suspect congenital anomaly and need to be treated by special and expert surgeons. Surgical intervention should only be considered if a concerted trial of medical therapy has not been successful, and not should be considered a first-line therapy, and don't put an effort to prove it or exclude it. That's the first lecture. I wish that points are clear, and we'll leave the discussion till the end of the second lecture. So I'll move to the second lecture, which is about the hormonal contraceptive device beyond contraception usage and benefit. The first recommendation is the use of the levonorgestrel intrauterine device is the US FDA approved for the treatment of abnormal menstrual bleeding, and it's the only progesterone IUD that has been evaluated for the treatment of abnormal uterine bleeding. There are other IUDs with, of course, hormonal IUDs with different doses and duration of use, but further study to rule or other device, the rule of the other device in this treatment purpose of treatment is needed. Based on the meta-analysis of the 6 randomized clinical trial published in 2009, the efficacy of the levonorgestrel intrauterine device in the management of heavy menstrual bleeding appeared to have a similar therapeutic effect to that of the endometrial ablation up to 2 years after treatment. So this is a very convincing point to believe in this method of treatment before exposing the patient of the endometrial ablation, especially if that is not a possible facility in the instruction in the place where you work, or you are not well trained on it. So don't try an invasive treatment when we have a non-invasive procedure that give you a similar efficacy, even on long-term follow-up. Women using levonorgestrel intrauterine device can treat the hormonal menstrual bleeding, maybe benefit from frequent removal and replacement regardless of the use of the recommended usage for the contraception. So we know that when we use the intrauterine device for the contraception, we replace it every 5 years. In contrast, when we use it for the treatment of abnormal uterine bleeding, menstrual suppression may be attenuated prior to 5 years of use, and the patient may benefit from more frequent removal and replacement of the device. So, especially if we put it for the patient and the patient started to get a real benefit after 2 years from the use, and then she started to have another bleeding. So we come across a real need to replace it in order to maintain the continuous efficacy. The needs of more frequent replacement of this setting maybe also reflect the declining of the intrauterine progesterone concentration during the use of this device. We don't know yet whether it is because of the higher consumption of the progesterone or because of the maintenance of the endometrial stability. So, but this is a well-noticed phenomena by Connacht et al. Published in 2012. In postmenopausal women who are wishing to use hormone replacement therapy in a form of estrogen alone, because whether they cannot tolerate oral progesterone, the effectiveness of endometrial protection was highly approved in some countries by using intrauterine device, hormonal intrauterine device, and that was well established and that was released in 2015 by Refreshment. Patient known with leiomyoma with a special position and sizes as well. In the Cochrane database published in 2006, there are no randomized trials to evaluate the use for the treatment of hormonal menstrual bleeding related to leiomyoma. But the observational studies and systematic review have shown there is a reduction in the uterine volume and bleeding, an increase in the hematocrit after placement of this device. So we can understand from this point, it's not a treatment for leiomyoma, but it can modify the symptoms of leiomyoma or the signs of leiomyoma in form of increasing uterine volume as well as decreasing the amount of menstrual bleeding during menstruation. Surgery, especially hysterectomy, this is the reduce the menstrual bleeding at 1 year more than medical treatment. Of course, this is the most radical treatment for leiomyoma and most approved treatment for leiomyoma to eliminate both symptoms and signs. When it comes to endometrial hyperplasia, patients were in a national multicenter trial by Orbo et al. Published in the British Journal of Obstetrics and Gynecology in March 2014. There were patients randomly assigned to one of 3 treatment arms. One were started to use the oral medroxyprogesterone acetate in a dose of 10 milligram administered for 10 days per cycle, or continuous oral medroxyprogesterone acetate 10 milligram daily for 6 months, or using levonorgestrel intrauterine device. After 6 months, all 3 treatment regimen showed significant effect when the outcome was evaluated as therapy response or not, with a significant p-value. So the response were obtained for all women in the levonorgestrel intrauterine device with 95% confidence interval, and from 0.9 to 1, while 96% in a woman continuous group of medroxyprogesterone acetate, and only 69% and only 69% for the women in the cyclic oral group were response. So this is a very supportive for the use of intrauterine device in patients with hyperplasia in a form of decreasing the amount of bleeding as well as the significant reduction in the endometrial thickness. The patients with histologically confirmed endometrial hyperplasia were treated with levonorgestrel intrauterine device 3, 6, and 9 months after insertion. A follow-up of endometrial aspiration biopsy with this patient were taken. And this is another study published in 2016 by also multi-center study by Korean Gynecological International Group, because I think this study helped us a lot to evaluate whether to take the patient for, to remove the device and take a biopsy, or take a patient for dilatation and curettage in order to prove whether this is really effective or not. So this study really gave us a very good relief from this dilemma, and at 12 months of follow-up, endometrial tissue were obtained via two methods: endometrial aspiration biopsy with levonorgestrel intrauterine device, and in the uterus, followed by dilatation and curettage after VNC and removal. And the study population compares 75 patients, including 37 with simple hyperplasia without tibia, 3 with atypical simple hyperplasia, and 23 with complex hyperplasia without tibia, 12 with tibia, typical complex hyperplasia. The complete regression rate at 12 months was 94.7%. A comparison of the pathological result from endometrial aspiration biopsy and DNC was carried out for 15 patients. In the histological result by endometrial aspiration biopsy, 4 patients were diagnosed as normal endometrium, and 1 as insufficient tissue for pathological evaluation. Among the 14 cases of normal endometrium by endometrial aspiration biopsy, 1 was diagnosed as residual endometrial hyperplasia by DNC, and 1 case with insufficient tissue was diagnosed as normal endometrial by DNC. So this is a very good study to support us to evaluate whether we use the DNC or endometrial biopsy. Tamoxifen, patients who are taking tamoxifen, we know they are at increased risk of having increased in the endometrial thickness and possibility of development of endometrial hyperplasia. So in a 4 randomized controlled trial involving 543 women taking tamoxifen were evaluated by Cochrane database review and by Dominique and published in December 2015. The active treatment arm was taking 25 microgram of levonorgestrel intrauterine device per day, and the control arm was endometrial surveillance alone. So the levonorgestrel intrauterine system lead to reduction in the incidence of endometrial polyp over both 12 months period and over long-term follow-up period, where 24 and 60 months. Levonorgestrel intrauterine system lead to reduction in the incidence of endometrial hyperplasia over a long-term follow-up period, 24 and 60 months. None of the trial were sufficiently powered to detect whether levonorgestrel intrauterine system lead to significant change in the incidence of endometrial cancer in tamoxifen user. So this is a very important point to pay attention to it. For fibroid, breast cancer recurrence, and breast cancer related deaths, there were no evidence of a difference between using the levonorgestrel intrauterine system treatment group and control for for these outcomes. In patients with PCO, after levonorgestrel intrauterine system insertion, in all patients, we found that menstrual blood loss was decreased and hemoglobin level was increased significantly compared to pre-insertion level, especially for those PCO with frequent menstruation and heavy bleeding. And the endometrial thickness was significantly reduced in all groups after 12 months. And this is an important point to concentrate on, because we know that some of the young group developing early stages and early grade endometrial cancer, they have a strong history of long-term untreated PCO. So most of the patients showed when we use this device in the treatment, they showed after 12 months from using, most of them showed transformation of the endometrial pathology with complete disappearance of simple and irregular cases of endometrial hyperplasia and decrease in the number of complex endometrial hyperplasia cases. In patients who are, say, ER/PR receptors positive, for those with whether they have an endometrial adenocarcinoma with ER/PR receptor positive, diagnosed by non-invasive procedures like endometrial biopsy and fractional curettage. There was 13 studies evaluated by Refreshment et al. In systematic review and meta-analysis published in ACTA Obstetrics Gynecology 2019. 13 studies with 635 patients were included in the systematic review. Patients' negative ER expression did not significantly predict poor response with low predictive accuracy. Negative PR significantly predicted poor response with moderate accuracy. In the oral progesterone subgroup, neither ER, PR had significant predictive value. In the levonorgestrel intrauterine device subgroup, both ER and PR were significantly predictive for good response, although accuracy was suboptimal. The atypical endometrial hyperplasia and endometrial endometrial intrauterine carcinoma subgroup showed non-significant result in data about non-atypical endometrial hyperplasia were not excluded. In cancer patients, selection criteria for candidate for conservative treatment of endometrial cancer, patient has to be diagnosed with well-differentiated grade 1 endometrioid adenocarcinoma, and this is need to be proved by a proper histopathology evaluation. No myometrial invasion, this can be evaluated by MRI, sorry. Okay, sorry. No extrauterine involvement, so no synchronous ovarian tumor or metastasis, and no suspicious retroperitoneal nodes, and this need to be evaluated by an expert radiologist. Strong desire for fertility preservation, and this is what I was talking about when we start to see a lot of patients with young patients develop endometrial adenocarcinoma with polycystic ovary, with background polycystic ovary. There's no contraindication for medical management, and patients understand and accept the data on cancer-related and pregnancy-related outcomes are limited. So we have to obtain an informed consent from the patient and her spouse. And this data were published by collected from ERCAN and ICAN in a fertility-sparing therapy in young women with endometrial cancer, published in Gynecology Cancer in 2010. Fertility-sparing treatment in case of endometrial carcinoma and complex hyperplasia. The 70 patients were included in the study analysis by Proin et al. In 2015, published 23, like 72%, with adenocarcinoma, and 92% and 92% of patients with atypical endometrial hyperplasia has a complete remission, defined as an absence of any carcinoma or hyperplasia on endometrial sampling, a specimen among these cases. 2 patients with adenocarcinoma and 1 patient with atypical endometrial hyperplasia has a recurrence after their complete response. 9 patients had persistent disease. 8 patients had 10 conception, resulting in 8 live birth babies. So the suggested conservative treatment strategy can be considered as a valid therapeutic option for young women with a childbearing potential, with atypical endometrial hyperplasia and grade 1 endometrial adenocarcinoma who wish to preserve their fertility, but that needs to be established by an expert oncologist, please, with respect to the general gynecologist, in order to properly selecting the patient and optimize and tailor the proper follow-up of the patient with taking in consideration all the consequences of the disease and early detection of any failure in the treatment. The beneficial of prophylactic effect of levonorgestrel intrauterine device also.
Your time up already.
Okay, I'll just
summarize it. Yeah.
Okay, so just quickly for the recommendation by the Royal College of Obstetrics and Gynecology, as I said before, the levonorgestrel device is approved treatment for the atypical uterine bleeding, and it's also for become an oral. It becomes superior to the use or comparable to the use of the oral progesterone therapy, and also it's very the levonorgestrel device is also superior to the cyclic progesterone therapy and the continuous progesterone therapy. And also women with HRT can get a benefit from using oral contraceptive therapy. The same recommendation also been mentioned by the Society of Obstetrics and Gynecology of Canada without giving details. And that was all. Thank you.
Thank you, Dr. Karima, for your nice presentations and your precious time during Ramadan. And there's a lot of questions in the question and answer panel from the participants regarding your both presentation. You can kindly and thankfully join the question and answer, and you can type the answer for them all. For those who are interested in the presentations, the presentation are on live streaming on YouTube channel for the Top House Conference company, and you can refer to it anytime to re-listen to the presentation. For the sake of time, we'll move for the next presentation. Will be with Dr. Samir Sindi. Dr. Samir Sindi, he is a consultant of obstetrics and gynecology, chairman of Saudi Group of Gynecology, Gynecologic Laparoscopy. He will talk about endometriosis. Welcome, Dr. Samir Sindi.
Assalamu alaikum. Thank you very much for all the speaker and thanks for participant. I'll go for the lecture. So we'll talk about endometriosis, and endometriosis, it's a presence of endometrial gland and stroma outside the uterus, while adenomyoma, it's isolated area of endometrial gland and stroma in the uterine muscle. Adenomyosis, it's a growth of endometrial gland and stroma into more than 2.5 millimeter from basalis layer of the endometrium. When you look to the epidemiology, that the 6 to 10% of reproductive age women has endometriosis, 38% of women presenting for infertility, it ranges from 20 to 50%, 71 to 87% of women with chronic pelvic pain. When you look to the worldwide, that 89 million worldwide have been estimated patients with endometriosis, while 6.5 million estimated in the US. Out of those, that estimated number of patients who are in physician in US is 43,000. It should be that 151 patients should be seen in the clinic, per clinic. When you look to this slide, you will see that the US government spending 880 million for outpatient care for chronic pelvic pain. It's quite huge amount of money. From those in the US, 6.1 of US women age 18 to 49 have diagnosed as endometriosis. This reflects how much is the patient going because of chronic pelvic pain. Out of those, 6.1 has diagnosed as endometriosis. So what about Saudi Arabia? We did a study in King Fahd Medical City. It's a tertiary care. It shows that with our colleagues, for our patients who have been operated by me in the surgery with my team, it's a tertiary care. Out of those, 14.3 patient has been diagnosed as endometriosis, while the other are for other causes has been done minimal invasive surgery for them. So it's a tertiary care, referral to hospital, but the cases are quite high. From those one, The peak age, you'll find that 34.1. It's quite high also. We look that it's before that. We hope that endometriosis will be diagnosed. You see here that most of those cases are stage 3 and 4. So we hope that endometriosis referral should be early on. This is a picture of one of my patients. She's keep running from one for looking for traditional method, and actually finally, at the end, she did cauterization because of the severe chronic pelvic pain and abdominal pain. We did for her laparoscopy. She was endometriosis stage 4. We don't want our patient to reach that stage. From our study, endometrioma that found it in the left 44%, while it's bilateral 26%, in the right 30%. The risk factor, it's included that early menarche, short cycle, patient were represented with heavy cycle, she may have obstructing Mullerian duct. I like to put this slide because you see that eyes don't tell the people what they see. People tell eyes what to look for. So we have to put in our mind other differential diagnosis. When I was in Australia a long time ago in 2003, Alan Lam was asking me, do you see a lot of cases of endometriosis? I answered him, no. In our society, we have high obstetric, so we didn't see. He answered me, probably there are a lot of cases, but you and the team are not able to diagnose it. But now, we are in 2020-21. Now we are able to diagnose endometriosis. Minimal invasive surgery is there. Treatment is there. So we move a lot from those one, and it's huge number of cases. Definitely society have been changed. You see that here, the symptoms, it's include dysmenorrhea, pelvic pain, infertility, dyspareunia, and menstrual irregularity, and dysuria and hematuria. When you do laparoscopy, you'll see that endometriosis, it could be there in the peritoneum, in the rectovaginal, it could be in the ovary, whether it's deep or superficial, or she developed endometrioma. This is a study. Here you see that they are looking for 20 items measuring 3 primary domains of environmental. Let us see what is it for. When you look for internationalized stigma, what does society feel about the teenager with endometrioma? I think this is important. Once you have one in your family or something, how is the society looking for it? It may be different from one society to another, from Middle East, from other part of the world. But I think in Muslim country and Arab world, they are looking for it different from the Western society. How those feeling and idea translated into action? What about does girl feel about her diagnosis as her classmate in the school don't have the same diagnosis or it's different? What about dyspareunia? You see, it's affect the society, it's affect her husband, it's affect her partner. The partner feeling that the sexual partner, he feel frustrated with the complaint of his girlfriend or his wife because of the pain. She feel that always she is using that pain as an excuse to withdraw from sexual activity, and this affects society. It may lead to divorce and so on, and it causes a major effect in the society. Let us see what happens to the Middle East. In the Middle East, we have actually in our mind that it's family, and mainly they want to form family and children. But majority of Arab worlds and Arab parents, they have in mind that, oh, she has menstruation, she is finally safe and sound. Once she will get married and she have a husband, all of these fear will disappear. That's what is there in their life, in their mind, and in their life. So when you look that menstruation in our words, that it's shameful, remaining patient is remaining in bed, she's taking analgesia, staying quiet, doesn't want their father especially to know that she has her menstruation, and this the problem which rises. Mother and other women, they keep talking in the society and between each other, oh, she is a young woman, she is facilitating to have some of those one and to have to adapt it, and she will use some mint and something hot drink and so on to relieve her symptoms. But the parent anxiety, when she see her daughters when she have menstruation or dysmenorrhea, while they are thinking of some questions which very difficult for gynecologists to answer it. She will ask, will she be able to have a normal sexual relationship? Will she be able to get pregnant? With this disease, will she get worse, what should tell her future husband, especially in cases of religion and the relation to the PCOS. So this question sometimes it's very difficult to answer. At the teenager, she may be seen by pediatrician, she will be seen by adolescent health physician, general practitioner, she may be seen by gynecologist and a school health specialist. These are some different pictures from endometriosis. You see that with adenomyosis, this is dark brown in the endometrium. So the lesion, it could be typical black blue or atypical white ossification, and could be red flame or yellow brown or translucent or peritoneal defect. These are different pictures of endometriosis. Some of those are our patients. This is, you see below the diaphragm, she is one of our patients, my patient. She has it at the liver below the diaphragm and she's endometriosis stage 4. This is the white ossification you see in the endometriosis. This is the adhesion. The idea that we are putting those pictures, so to be aware that it's endometriosis, we have to diagnose it early. Laparoscopy is the only definitive diagnosis. It's a golden standard. To show diagnosis, we have to take it. And the treatment for each endometriosis should be individualized. You have to take the clinical problem in its entirety. You have to know impact of the disease, effect of the treatment, of quality of life of the patients, and the goal of suppression, that our goal that to have to suppression of ovarian activity and menstruation and atrophy of endometriotic implant. It could be either expectant, medical, surgical, or combination of those medical and surgical. The aim of medical therapy, that elevating of the severity of the symptoms, you have to have acceptable safety profile, improvement in the woman of quality of life. The treatment, that it could be that conventional, as all of you familiar of it, different combined oral contraceptive, progesterone, gonadotrophin releasing hormone, intrauterine contraceptive device, oral gonadotrophin, progesterone antagonist. It's quite long list. So let us see what happens. A new publication journals in England in July 2017, they said that treatment of endometriosis associated with pain for a new treatment, oral GnRH antagonist, Elgolex, it shows that in the New England Journal of Medicine 2017, a total of 872 women underwent randomization. In conclusion, the use of Elgolex at 2 doses, one which was 150 milligram once daily and 200 milligram twice daily. The result was reduction in the 2 of hallmark pain symptoms of endometriosis, dysmenorrhea, and non-menstrual pelvic pain. After both 3 and 6 months of the treatment, constant with mechanism of action, Elgolex treatment resulted in hypoestrogenic effect, including hot flushes and changes in bone mineral density and lipid profile. So what about Dynogest Fizan? Dynogest, it's a selective progestin combining the pharmacological property of non-progesterone with progesterone derivative. It has a pronounced effect on endometrial tissue with absence of androgenicity and moderate suppression of ovarian activity. Dynogest has a lower incidence of hypoestrogenic side effect when you compare it to other drugs like gonadotrophin releasing hormone agonist. It's safe and effective when it's taken even for a long time when you compare it to other drugs like Liparon or others. Bone mineral density reduction are less when you compare it to other gonadotrophin releasing hormone agonist. It has less cost than gonadotrophin releasing hormone agonist. The dose, as you are or more familiar of it, is 2 milligram. Daily has to be taken orally for up to 24 weeks. You start it directly and patient will continue with it. Here in this slide, you see that there is comparison between Liparon and comparison with Fizan, Dynogest. You see that the vaginal dryness in Dynogest, it's less, as you see, and with hot flushes also it's 0, while with Liparon it's 9. So it's almost none in hot flushes. Here, when you look for this paragraph, you will see that Fizan is proven to be suitable for long time treatment because you don't want the side effect with other drug that she may develop, especially when you are using it for quite long time. So here it's safe for long-term treatment. What about some of those patients we are doing second laparoscopy? For those patients, it's here from this paragraph, you see that diagram that the second look laparoscopy after 24 weeks is 80% of the patient, none or only minimal endometrial was detectable. But my message here, if you are expert in endometriosis, do the surgery. It should be the first surgery is the most important surgery to be done, because he will do the best, it should be in the best hand, removal of the whole endometriosis, the patient she will be improved and the recurrence rate will be reduced, and especially after how many years. You see here, Fizan have reduced the severity of endometriosis in this paragraph. So the clinical tip, which we want to say, that pelvic pain that is not primary dysmenorrhea should be considered endometriosis until proven otherwise. Endometriosis should be considered early in the differential diagnosis of pelvic pain in a young woman. Then there is always a delay of 7 to 12 years from the onset of symptoms of definitive diagnosis. We want to break that cycle. We don't want it actually after 7 to 12 years, the patient will be diagnosed with endometriosis. This will be helpful if the patient was referred early diagnosis. The society will play a role in that one to transfer it to the gynecologist. And once she has pain, the advantage of clinical or medical intervention that it decreases initial cost. Sometimes you are using it for umbilical therapy. Sometimes we use it because it's non-invasive. It's effective for pain control. While the disadvantage of medical intervention that it has adverse effects are common, and especially in some of the drug, it's not likely to improve fertility. Some can only be used for a limited period of time. Endometriosis and endometrioma, it's like an iceberg. You see here, you see the top, while the bottom one in the sea, you'll see quite big one, huge one, so you don't know what is there behind. دائما نتذكر والدينا وخصوصا في رمضان، أوصيكم وأوصي نفسي وقل رب ارحمهما كما ربياني صغيرا واخفض لهما جناح الذل من الرحمة وقل رب ارحمهما كما ربياني صغيرا. رحم الله والدينا ووالديكم. Endometriosis with the pain. Now we move to surgical treatment. It could be conservative. You do ablation, you do excision, you have to do lysis of the adhesion, but you have to restore the anatomy. Very rarely we do total abdominal hysterectomy and bilateral salpingectomy. The conservative surgery, our goal is that to attempt to restore the normal anatomy and to remove the visible lesion. The technique that it may include that excision or destruction via laser or electrocoagulation directed at the surface of the lesion, and you do lysis of the pelvic adhesion. Always we compare what is the advantage of surgery, what is the pros and cons. The advantage that you have definite histological diagnosis, so you exclude ovarian carcinoma. You have the patient dramatically, her symptoms will improve, her improvement in fertility outcome. While the disadvantage that there is maybe reduction in the ovarian reserve, the risk of premature ovarian failure, it could be later on, it could be high recurrence rate, but in not safe hand surgeon. The endometrioma, the recurrence of ovarian endometrioma is increased 7 to 30% after 3 years and after 5 years also. The recurrence of endometriosis is a cause of repeated surgical and medical intervention because maybe you need to operate on the patient again. Repeated surgery may compromise ovarian function, reducing ovarian tissue. How to avoid recurrence? I think it should be in the best hand of surgery. The first surgery is the most important. You have to perform surgery in the follicular phase. You have to achieve amenorrhea by using different drugs like Fizan, progestin, gonadotrophin releasing hormone, agonist. You have to add back other regime using oral contraceptive, using Marina, and so on. So when you look to this paragraph, you see the recurrence after 4 years from this study and 8 years. In the ovarian, after 4 years, 24.6. After 8 years, 42. Pelvic, it's 17.8. 8 year, 24.1. And for deep, 30.6. And after 8 years, 43. Ovarian and deep endometriosis, 23.7. After 8 years, 30.9. The advantage of surgery is that it has a significant efficiency for pain control. It has increased efficiency over medical intervention for infertility treatment, Combined with the biopsy, it's the only way to achieve a definitive diagnosis of endometriosis. It can often be carried out as laparoscopy to reduce morbidity and minimize the risk of post-operative adhesions. These are some of the ultrasound picture which shows about endometrioma. And these are some of the endometrioma pictures. And with the dark brown, you take a biopsy from the peritoneum and you send it to histopathology. So what about endometriosis with infertility, tubal or anatomical distortion, oocyte dysfunction, ovulatory dysfunction, sperm DNA damage, reduced fertilization, and implantation? Significantly concerning infertility, its improved implantation rate will be improved, pregnancy rate improved, live birth rate of Litterfield is increased, the surgical removal of minimal and mild endometriotic lesion. It also gives a shorter time to the first pregnancy and higher cumulative pregnancy rate. And the clinical tip for the infertility, that adherence to the principle of microsurgery, because you don't want your patient to develop adhesions. So diligent hemostasis, reduced fulguration, and limited use of suture. It should not be used any suture, and may improve fertility. Excision is preferred over fenestration, drainage, or ablation of the cyst lining for the treatment of ovarian endometrioma. It should be all removed. The cyst, don't leave anything because of the recurrence. Some people, they use adhesion prevention. It may help reducing adhesion formation, but improvement of fertility is unknown. Concerning ovarian carcinoma, the prevalence of ovarian cancer in patients with endometrioma is unclear. 1%. Excision of sampling of suspected endometriosis lesion and endometrioma help to confirm the diagnosis and exclude underlying malignancy. Clear cell and endometrioid carcinoma are the most common entities to be associated with ovarian endometriosis. I'll say that always when you make a management for a patient for endometriosis, because each case, it should be treated separately and differently, that important to involve the patient or the woman in all decision you are making. You have to be flexible because it's going to be different from time to time. Flexible in the diagnosing and therapeutic thinking. Some of them, they want to get pregnant and so on. So you have to be flexible. You have to maintain a good relationship with those patients because they have a social problem, they have a family problem, they have a family with her husband and so on. You have to seek advice. When difficult cases, you have to seek advice where appropriate from more experienced colleague from endometriosis. At the end, I'll say the patient with endometriosis suffer a lot. She will go for a journey. It could be going to sexologist, pain specialist, gynecologist, fertility expert, psychologist, patient society, and physiotherapy. Why I remember this one? One of our colleagues, he's a consultant now, senior consultant as a gynecologist. He's telling me when we were in Australia, he said, I was praying to my God that I not have my wife to have gyne-oncology. But unfortunately, gyne cancer or so on, because he saw a lot of cases of gyne-oncology. But unfortunately, his wife, she had endometriosis. So he's going a lot for those journey. So please take care of endometriosis and your patient, and I'm sure of that. Thank you very much.
Thank you, Dr. Samir, for your presentation. We will move to the next speaker with us, Dr. Majid Al-Hadhoud. Dr. Majid, he is a consultant OB-GYN and IVF doctor in Dr. Sulaiman Al-Habib Medical Group, Al Rayyan Hospital in Riyadh. He will speak in the next 30 minutes about diagnosis and risk assessment of polycystic ovary syndrome, the recent update, and he will discuss the premature ovarian insufficiency. What is the chance of conception? Welcome, Dr. Majid.
This will get some new insight into the topics we're going to touch today. My first presentation will be about the polycystic ovary syndrome, but we'll look at different angle. We look at the screening, diagnostic assessment, risk assessment, and life stage. and I will rely heavily on the international evidence-based guideline for the assessment and management of polycystic ovary, which has been actually including more than 37 PCOS professional bodies and organizations across 71 countries, and addressed 60 clinical questions and included 40 systematic and 20 narrative reviews, and issued 166 recommendations. Sorry. Now, they have prioritized the clinical questions into 5 groups. And today our talk is about the first group, which is the screening, diagnostic assessment, risk assessment, and life stage. The guidelines actually label their or categorize their recommendations into 3 categories: evidence-based recommendation, when there is evidence sufficient for the recommendation, or clinical consensus recommendation in the absence of adequate evidence. The third one is the clinical practice point when the evidence was not sought. Now, go into the subject. You know, they rely also on Rotterdam criteria for diagnosing polycystic ovary syndrome, which is 2 out of 3. The first one is the menstrual irregularity. The second one is the hyperandrogenism, whether clinical or biochemical. And the third one is the ultrasound. So we're going to look at to redefine those criteria basically here based on the current evidence. So for the irregular menstrual cycles, the definitions they came to in the first year of post-menarche, it is normal to be irregular. So we cannot label the patient with irregular menstrual cycle in the first year post-menarche. And in fact, in the first year after menarche, up to 90 days of any one cycle is fine, is still normal. If it is more than 90 days in one cycle, then we can say this is abnormal. And between the first and 3 years post-menarche, anything between 21 and 45 days is normal. So again, there is difference from people with 3 years post-menarche. So between 3 years post-menarche and perimenopause, the normal cycle should be anything between 21 and 35 days, or more than 8 cycles, or less than 8 cycles per year. So, I mean, the normal is between 21 and 35 days, or at least 8 cycles per year. Anything about out of that would be abnormal. Now, for the adolescents who have features of polycystic ovary but do not meet the diagnostic criteria, we should label them as increased risk, and we will assess them 8 years post-menarche after the full reproductive maturity. And this includes those with polycystic ovary syndrome patients with features before the commencement of combined contraceptive pills, or those with persisting features, or those with significant weight gain in the adolescents. Now, the biochemical hyperandrogenism, they stressed on too many things actually in this subject. First of all, you need to use the calculated free testosterone, or the other calculation is the free androgen index, or calculated bioavailable testosterone. In fact, if you want to use the free testosterone direct assay, then you have to use high quality assays such as liquid chromatography, mass spectrometry, which is not really available in most of these institutions. So if you don't have this high liquid chromatography technique, then you need to use the calculated free testosterone. Regarding the androstenedione and DHEAS, dihydroepiandrosterone sulfate, could be considered if the total or free testosterone are not elevated. However, these have probably limited additional information in the diagnosis of polycystic ovary syndrome. So, as a single measure, free testosterone provides the most accurate test for the hyperandrogenism in patients with PCOS, followed in no specific order by the total testosterone, dihydroepiandrosterone sulfate, or androstenedione. DHEAS is mildly elevated in patients with PCOS, but significantly elevated when there is, or if there is virilization, then we have to investigate for adrenal tumor. Androstenedione is elevated in non-classical congenital adrenal hyperplasia, which is again very important diagnosis to rule out before reaching a diagnosis of polycystic ovary syndrome. And the most important thing with the testosterone assessment, it should be preferably done during the early follicular phase, the first 8 days of the menstrual cycle and cycling women, and it should be at 8 o'clock in the morning to get the most accurate results. As we said again, direct free testosterone assays such as radiometric or enzyme-linked assay preferably should not be used, as they demonstrate poor sensitivity, accuracy, and precision. So please check with your lab which test they're using. So please avoid using the direct free testosterone assays. Other point, actually, when we're measuring the hyperandrogenism by the chemistry, you need to make sure that the patient is not taking oral contraceptives for the last 3 months before having the measurement. And if so, you need to stop it for 3 months and be careful of using alternative contraceptive measure when you're waiting for the test. Now, assessment of biochemical hyperandrogenism is most useful in establishing the diagnosis of polycystic ovary syndrome and or the phenotype when clinical signs of hyperandrogenism are unclear or absent. Regarding the clinical hyperandrogenism, the clinical signs and symptoms are the acne, alopecia, and hirsutism. However, in the adolescents, only severe acne should be included, not mild acne. When we're talking about the reported unwanted excess hair growth and or alopecia, it should be considered important regardless of the apparent clinical severity, because it has potential negative psychological, psychosocial impact on those patients. So don't take it lightly. In fact, you need to pay attention and treat it accordingly. Now, when we're talking about the hirsutism, there is a standardized visual score, and I prefer to use one of them and like modified Ferman-Galloway score with a level of more than or equal to 4 to 6, indicating hirsutism, obviously depending on the ethnicity, because we have to acknowledge that there is variation between ethnicities. So the total score in white women should be, let's say, 8 before labeling the patient as having hirsutism. And we have also to acknowledge that self-treatment is common and can limit the clinical assessment of the hirsutism. This is the modified Galloway score, which include or grade 9 body areas from 0 to 4, where 0 has no hair and 4 has frank, virile, and then the calculation would be up the maximum 36. So as we said, for white women, for instance, anything above 8 considered hirsutism. Overestimation of the hirsutism may occur if vellus hair is confused with the terminal hair. So we have only to rely on terminal hair, and it should be more than 5 millimeters in length if untreated, obviously varying in shape and texture and generally being pigmented. Regarding the acne, there is no universally accepted visual assessment for evaluating acne. For the alopecia, Loddig's classification is the preferred to assess the alopecia with 3 types, as you can see here in the picture. Now, regarding the ultrasound morphology of polycystic ovary, this is very important to state here. Patients, ultrasound should not be used for the diagnosis of PCOS in those with gynecological age less than 8 years after menarche. So we need obviously to wait until after 8 years of post-menarche to rely on the ultrasound as a tool to diagnose polycystic ovary syndrome, because of the high incidence of multifollicular ovaries in this life stage. Now, the threshold for polycystic morphology also should be revised regularly, and advancing ultrasound technology and age-specific cutoff values should be defined, because the transvaginal ultrasound approach is the preferred in comparison to the abdominal one if the patient is sexually active and it is acceptable for the patient. And the most recent devices now have a bandwidth of 8 megahertz. So with this new technique, with high resolution, you have better appearance or diagnosis of polycystic, and you see more follicles. And for that reason, we have to revise the criteria to label the patient as polycystic morphology. We need to have more than 20 follicle on one ovary at least, and the volume of 10 milliliter, ensuring obviously when you take the volume of the ovary, there is no corporeal lutea or cyst or dominant follicles are present when you're having the volume measurement. Now, you can see between the two pictures here, the above picture, slightly better resolution than the one underneath. So if you're going to use all the technology, we ideally rely on the volume of the ovary, and it should be more than or equal to 10 milliliter. If the patient with irregular menstrual cycles and hyperandrogenism, ovarian ultrasound is not necessary to diagnose the polycystic ovary syndrome. However, it is maybe important to identify or complete the phenotype to put the patient into which category of the phenotypes. And if using abdominal scan, as we said, it's difficult to assess the number of antral follicles, so we have to rely only on the volume with this technique. You can see here the new and old techniques. The old technique probably will not be able to show the tiny follicles that you can see on the other side. So the recommendation actually, when you have ultrasound, we have to have a protocol reporting the ultrasound findings in order to enable to reach accurate assessment of the polycystic ovarian morphology, and should include the last period, the bandwidth of the frequency of the probe, the approach, whether it was vaginal or abdominal, the total number of follicles due to 9 millimeter, the 3-dimensional or the volume of the ovary, reporting the endometrial thickness and appearance, and other pathology. AMH, serum AMH should not be used as an alternative or for the detection of polycystic ovary morphology or as a single test for the PCOS. Ethnic variety, we need to bear in mind that there is a relatively mild phenotype in Caucasians and higher body mass index to show the symptoms, more severe hirsutism in Middle Eastern, Hispanic and Mediterranean women, increased central adiposity, insulin resistance and diabetes, for instance, in East Asian and Australian. Lower BMI and milder hirsutism with East Asian group, and higher BMI and metabolic features in the African ethnicity. Menopause life stage, only women with previous diagnosis of polycystic ovary before menopause can be still labeled as polycystic ovary postmenopausal. But in case of patients started to have a new onset or severe onset or worsening hyperandrogenism after menopause, then this requires further investigations to rule out ovarian or adrenal tumors. Now, regarding the risk assessment, cardiovascular risk assessment is very important, and all women with polycystic ovary should be regularly offered monitoring for weight changes or excessive weight gain, and that could be probably every 6 or 12 months, and that should include the BMI and the waist ratio. And based on that, you can assess the risk according to the WHO classification. As you can see here, when you have, increased waist circumference can also be a marker of increased risk even. So we need to combine both. This is the recent recommendation actually. And all women with polycystic ovary should be assessed for the cardiovascular risk factors, and risk factors including obesity, smoking, dyslipidemia, hypertension, impaired glucose tolerance, and lack of physical activity, those considered as increased risk for cardiovascular disease. And overweight and obese women with PCOS, regardless of their age, even in the teenage, probably should have a fasting lipid profile. And obviously, after that, if they have it abnormal, then they need to frequently have it monitored. So also all women with PCOS should have blood pressure monitoring annually. And despite the fact that cardiovascular risk in women with PCOS remains unclear, pending high-quality studies. However, the prevalence of cardiovascular risk factors is increased, which means like we have to consider the screening for those women. Regarding the gestational diabetes, impaired glucose tolerance test, and type 2 diabetes, I think everyone among us agree that regardless of age, the prevalence of gestational diabetes, impaired glucose tolerance, and type 2 diabetes are significantly increased in PCOS group with risk independent of yet exacerbated by obesity. So even non-obese women, they are exposed, but this will be exaggerated by the presence of obesity. And 5-fold increase of this risk in Asian, 4-fold in Americans, and 3-fold in Europe. Glycemic status should be assessed in all women with PCOS, and it should be every 1 to 3 years, influenced by the presence of other diabetes risk factors, which tests we can do: fasting plasma glucose, hemoglobin A1C, or OGTT to assess the glycemic state. However, in those patients with high risk, OGTT is the preferred. High risk including BMI, as we said, above 25, or in Asian, lower BMI, which was 23, or if there is any history of impaired fasting glucose or insulin, impaired glucose tolerance, or gestational diabetes in previous pregnancy, or if there is a family history of type 2 diabetes. Obviously, the presence of hypertension and high-risk ethnicity warrant OGTT. 75-gram OGTT is the recommended and should be offered to all women with PCOS preconception when planning for pregnancy or seeking fertility treatment. And if not performed preconception, the moment she got pregnant, we should do it before the week 20. And obviously, regardless of the results of those, all women with PCOS should be offered the test at 24 to 28 weeks gestation. Obstructive sleep apnea, again, this is something new for the polycystic ovary syndrome that we need to bear in mind. And screening should only be considered to identify and alleviate related symptoms: snoring, waking unrefreshed from a sleep, daytime sleepiness, and potential for contributing for fatigue and to contribute to mood disorders. So we need those patients to be screened, and probably we can use Berlin tool as a questionnaire, and you can assess the patient based on that. And if you see that they are at risk of obstructive sleep apnea, you can refer them to the respiratory team. Endometrial cancer, there is increased by 2 to 6 folds with polycystic ovary syndrome patients, and despite the fact that the absolute risk remain relatively low. And we should have low threshold for investigations of endometrial cancer in women with polycystic ovary syndrome or history of polycystic ovary syndrome by doing the ultrasound scan, preferably vaginal ultrasound scan, and or endometrial biopsy is recommended. And this is most important with patients with persistent thickened endometrium and the presence of risk factors including prolonged amenorrhea, abnormal vaginal bleeding, or excess weight gain. The recommendation said routine ultrasound screening for endometrial thickness is not recommended in PCOS patients. And the optimal prevention of endometrial hyperplasia and endometrial cancer is not known. However, a pragmatic approach could include combined contraceptive pills or progesterone therapy in those with cycles longer than 90 days. So better to induce a bleed every 90 days at least. So in summary, it is normal to have irregular menstrual cycle in the first year post-menarche, and free testosterone provide the most optimal for biochemical hyperandrogenism assessment. And in adolescents, severe acne would be considered as a sign of clinical hyperandrogenism. Ultrasound should not be used for the diagnosis of polycystic ovary syndrome with a gynecological age of less than 8 years after menarche. If using transabdominal scan or older transvaginal scan, the criteria for ovarian volume, a threshold of more than or equal to 10 milliliter is preferred. Antral follicle count is not reliable. AMH should not be used as an alternative to ultrasound or as a single test for the diagnosis of PCOS as yet. Although PCOS should be offered, all those with PCOS should be offered regular monitoring for weight changes, blood pressure, and to be assessed for cardiovascular risk factors and global cardiovascular disease risk. Glycemic status should be assessed at baseline in all women with PCOS, and OGTT should be offered in all women with preconception. Obstructive sleep apnea should be considered to identify and alleviate related symptoms, and there should be low threshold to investigate women for endometrial cancer. Thank you. I think we're going to leave the questions to the end of the presentation, and I probably will start with the second presentation. Now, this is a brief talk about the premature ovarian insufficiency and the chance of conception. There are different criteria actually to define the premature ovarian insufficiency, but ESHRE one is probably most reasonable, which include the three criteria. The first one is to have a primary or secondary amenorrhea for more than 4 months, and the onset should be under the age of 40, with FSH more than 25, determined by 2 measurements at least 4 weeks apart. Now, the term of premature ovarian insufficiency is preferred over the premature menopause or premature ovarian failure because it does not imply a total cessation of ovarian activity. The incidence is relatively low, with occurrence of 1 in 100 women before the age of 40, and 1 in 1,000 women before the age of 30, and 1 in 10,000 before the age of 20. The main mechanisms have been suggested as potential causes of premature ovarian insufficiency include either early follicular depletion, a blocking of follicular maturation, or destruction of the oocyte pool. The possible causes could be genetic, iatrogenic, autoimmune diseases, metabolic disease, infectious like the mumps, environmental, or idiopathic, which is about 50 to 90% of the cases. Now, what is the chance of pregnancy in those patients? In fact, it is uncommon, and probably the easiest solution is the egg donation for them for their subsequent infertility. However, in 5 to 10% of the cases of premature ovarian insufficiency, pregnancy can occur either naturally without any intervention, or with hormonal replacement therapy, IVF, or more recently the in vitro maturation or activation, and or the stem cell therapy. So to date, there is no clinical test to determine the potential for conception in patients with POI. It may be clinically prudent not to be too premature in diagnosing absolute infertility in women diagnosed with POI, especially those under the age of 30. So I think we should give them a little bit of hope, because this will allow patients time and opportunity to have a chance to conceive. So what does the evidence say? In fact, there are case reports of too many cases with pregnancies. You can see from those here the intervention and number of studies, and probably the pregnancies reported. With no treatment, we can see 8 pregnancies reported. With HRT, we have 12 cases, HRT and triggering, HRT and stimulation, ovarian stimulation with either recombinant FSH or HMG or together. You can see some reported cases. HRT after autologous stem cell transplantation, combined contraceptive pills, and then FSH stimulation, estrogen alone or estrogen with agonist. You can see different protocols with the steroids, prednisolone or dexamethasone, recombinant FSH. So it is long list. So there are some reported cases of successful pregnancies. Now, when we go for the systematic review to see the evidence around it, we can, out of 2,053 reported or records from the database searching, we found 15 studies, including 2 randomized control trials, 2 observational studies, and 2 interventional studies. And those two randomized trials, we can see 50 patients in the first case and the 58 patients in the second randomized trial. The first one has 2 groups, almost similar age group, around 32, with FSH around 68, mean FSH, and amenorrhea of about 17 months, so almost like equal in both groups. And the intervention was to give ethinyl estradiol 8 hourly for 14 days plus the recombinant FSH. The other group was given instead of the ethinyl estradiol placebo. And you can see 4 successful cases out of 25 in the arm with the estrogen treatment, and no cases of pregnancy on the other arm. The same for the second trial, randomized trial. They tried the GnRH analog plus the dexamethasone as intervention, and then they gave the HMG 300. The other group as well, having the same categories, probably the age of 28 and FSH at 54 and 48. You can see also the only difference is the steroids. The first group was given dexamethasone 6 milligrams for 28 days, while the other group was given placebo, in addition to the GnRH analog and the stimulate HMG, human menopausal gonadotrophins. And you can see in the arm with the dexamethasone group, they have 2 reported pregnancies out of 29 cases, while no pregnancies reported in the other arm. However, because of the limited number of cases involved in those studies, the powerful of the study is moderate, and they haven't reached statistical significance. The uncontrolled interventional studies, you can see long list again of studies with interventions with variable interventions here. You can see the intervention starting from estrogen valerate, and plus minus oral progesterone, HRT, DHEA, IVA, which is the in vitro activation, plus autotransplantation. And you can see some pregnancies here. You can see in the middle the pregnancy percentage, 2.2 up to 8. Obviously, DHEA a little bit biased the study because they have 5 cases, all of them get pregnant. No other supporting studies actually about the DHEA. Now here are other observational studies with the intervention was to give HRT or no. And you have in the first group 17% pregnancies, which is 3.3% pregnancy rate. And in the other group, you can see 9 cases out of 21. The age was about 33. So younger patients probably have higher chances of conception. So pregnancies and live births are uncommon in patients diagnosed with POI, but are not impossible. And indeed, POI is not always an irreversible condition. And spontaneous resumption of ovarian function occurs in about 25% of patients. And a great number of pregnancies have been reported for patients treated with HRT or oral contraceptive pills before, followed by ovarian stimulation. The HRT and corticosteroid mechanism of action, how come those patients can have higher chance of conception? In fact, the theory is lowering circulating concentrations of FSH and exogenous estrogens may allow downregulation of the gonadotrophin receptors to regenerate and regain responsiveness to pharmacological stimulation. And an associated hypothesis is that the decrease of LH as well, through the same mechanism, same negative feedback, could improve the egg quality by preventing early luteinization. The mechanism of action of corticosteroids is thought to be a reduction in perifollicular inflammatory macrophages around follicles, which can then restore folliculogenesis from dormant small follicles. How about the DHEA? It has been described in patients with low ovarian reserve, and this improves the intra-ovarian environment through the insulin-like growth factor 1, increases the production of estrogen, progesterone, and the number of FSH receptors, resulting in higher number of growing preantral and small antral follicles. Just to go back regarding the DHEA, obviously there are studies, randomized trials, actually could not show any improvement in the pregnancy rate with premature ovarian insufficiency. Now, the in vitro maturation is based on the premise that some women with POI still have the preantral follicles, And the physiopathology includes mechanical and biochemical signaling pathways. The methodology is fragmentation of ovarian tissue in vitro seems to disrupt the hyposignaling pathway, leading to the development of remnant follicles. Then these fragments are incubated with ACT-stimulating drugs promoting follicular growth. And finally, the fragments are replaced in the patient, and then the patients undergo FSH superovulation. 3 studies have been published using the IVM protocol with the birth of 3 healthy babies. The stem cell therapy, stem cell technique, the physiopathology is not clearly understood. However, some women with POI have achieved a natural pregnancy after bone marrow transplant after chemotherapy. And the hypothesis is that the attraction of undifferentiated cells in the ovary allows for the regeneration of the intra-ovarian environment, which in turn rescue the remnant follicles. This seems to have been confirmed in a study also by Harris in 2018, in which an infusion of bone marrow-derived stem cells in a xenograft of human ovarian cortex from poor responders transplanted into mice, resulting in promoting a follicular growth of the pre-ovulatory stage and increased vascularization. In another study, stem cells directly injected into the ovaries of poor responders patients, and some of the patients showed improvement in the antral follicle count and AMH levels. But the lack of response in some of the cohorts highlights that some profiles are probably more prone to respond to this treatment in comparison to others. And 5 pregnancies were obtained during the follow-up, and 3 healthy babies were born. Both studies, however, showed or included poor responder patients instead of patients with premature ovarian insufficiency. So the sole study using stem cell technology in patients with POI used umbilical cord mesenchymal stem cells associated with HRT treatment, and 1 pregnancy was ongoing at the time of the publication. What is in the pipeline? I would always be optimistic, never give up. And you can see in February, 2 months back, there is reported case of successful spontaneous pregnancy and live birth in a woman with premature ovarian insufficiency and 10 years of amenorrhea. So I think this is the take-home message: never give up. Don't usually let them down. And the other, also February this year, live birth in women with premature ovarian insufficiency receiving ovarian administration of platelet-rich plasma in combination with gonadotropin, a case report. So there is still ongoing research actually to see the best way to help this group of patients that we usually see in our practice. In fact, in conclusion, POI is a complex disease with a wide variety of causes. And because of heterogeneity of the population, randomized controlled trials are difficult to set up. No treatment for infertility has so far shown superiority. HRT remains a cornerstone for treatment to optimize their bone health and cardiovascular risk. However, it cannot be considered as a fertility treatment, but it is a win-win situation. When you use it to protect the health of the patients, you're lowering probably the hormones in the body and probably enhancing the chance of natural ovulation and probably conception. IVM and stem cell therapy and probably the PRP are likely to be in the future treatment for them and may generate a new hope for those patients. Thank you very much. Thank you, Dr. Samir.
Thank you very much, Dr. Majid, for your interesting both lectures. There are some questions actually in the question and answer. So if all the speaker could answer it, it will be great actually. We are running shortage of time, so we'll go for the next talk, which is by Dr. Khalid Abdel Halim. He's the head of women health care therapy area from Bayer from Dubai. And sorry to keep you the last before the breakfast in Dubai. Welcome, Dr. Khalid.
Dr. Samir. Hopefully you can see my slides now. Please allow me first to congratulate you on the wonderful webinar and the more than 1,000 participants. It's really a great success. رمضان كريم to all. ربنا يتقبل من الجميع الصلاة والصيام وصالح الأعمال. My presentation today will focus on the three main differences between YAS Plus and the other combined oral contraceptive pills. I'll focus mainly on the regimen, the 24/4 versus the 21/7. The drospirenone and the folate part was really nicely covered by Dr. Wissam at the first presentation. So starting with YAS, as we all know, is coming as a 28 pills for daily intake without a physical break, while we all know that there is a 4 placebo tablets, but this allow maybe higher adherence and maybe minimize missing pills if we allow a physical break. Why we shorten the usual 7 days break or the hormone-free interval from the 7 days to 4, and even in some other products to only 2 days. What was the driving causes to that? Mainly, they found in certain studies that the hormone withdrawal adverse events was more likely to happen during the 7 days pill-free interval than the 21/7 days. Another reason was due to the lower doses of estrogens used nowadays in the modern OCs, if compared to the older one with the 50 microgram of estrogen or more even. So the ovarian suppression may be lower with this lower doses, especially that the 7 days interval may allow the FSH to increase and may lead to a follicular growth and development. So here we can see that pelvic pain, headache, breast tenderness, and other adverse events was significantly higher during the 7 days pill-free interval rather than during the 21 days of hormonal treatment. In another study where we compared two drospirenone-containing pills, both pills containing the same amount of estrogen, 20 microgram, and the same type of progesterone drospirenone 3 milligram, but the only difference was with YAS is coming as a 24/4 and Yasminel as a 21/7 regimen. And we allow 2 cycles of regular pill intake, and at the 3rd cycle, we allow 3 days of missing pills. We can find here the follicular development. Of course, pre-treatment, more than 80% of the cycles were ovulatory. And when we take the pills regularly, we usually have little ovulation or follicular development in both regimens. But when the woman forget the tablets, we can see here a lot of ovulation and follicular development if we compare the 21/7 to the 24/4 regimen. Not only that, even with regular pill intake, we can see here very low chance for follicular development if we compare it to here a higher proportion of follicular development. That means with the 24/4 regimen, using the same amount of estrogen and the progesterone, we can get higher ovarian suppression. This, of course, reflected on a higher contraceptive effectiveness, and we can confirm that from a prospective randomized controlled active surveillance studies done in USA and 6 European countries. And it compares the 24/4 regimen of YAS Plus versus the conventional 21/7 regimens. It included more than 85,000 OC users that represents more than 200,000 woman year of observation and 150,000 woman year of exposure. And the results were a significantly more or significantly less, actually, less failure with the 24/4 regimen than the conventional regimen. The hazard ratio was 0.7, and it was a statistically significant difference. That means 30% less chance of failure. In Europe, actually, the hazard ratio was 0.5. That means even a higher chance of success with the 24/4 rather than the 21/7. The second difference actually with IAS is the progesterone content, the drospirenone itself. We know that all the synthetic progestogen, in addition of being a progestogen, they usually tend to have another activities like estrogenic or anti-estrogenic, androgenic or anti-androgenic, glucocorticoid or anti-mineralocorticoid. What's important here is drospirenone is the only progestogen that have both anti-androgenic and anti-mineralocorticoid. The anti-mineralocorticoid of drospirenone actually is by blocking the aldosterone receptors. By doing that, it resembles the natural progesterone and it tends to prevent the estrogen-induced water retention. Estrogen is usually stimulate the RAS system by promoting the synthesis of angiotensin in the liver, which is a substrate for the renin. So angiotensin is converted to angiotensin 2 by the ACE enzyme and then stimulate the aldosterone release from the adrenal cortex. Drospirenone is blocking the aldosterone receptors and lead to counteracting the estrogen-induced water retention. This can reflect on improved water retention symptoms during the premenstrual week and even the week of menstruation in both the new users and switchers from other OCs. Not only the water retention symptoms, but also the psychological symptoms like anxiety, mood swings, positive well-being, all improved with drospirenone due to its mainly the anti-mineralocorticoid effect. The anti-androgenic effect, on the other hand, in a two identical design placebo-controlled studies on more than 1,000 women with moderate acne, we can see a significant improvement in both types actually of lesions, the inflammatory and the non-inflammatory lesions after 6 months of treatment with IAS+. Not only the improvement of acne, but it's a general improvement of skin and hair due to the reduction of sebum production. The folate part is actually nicely covered with Dr. Wissam, and we all know the importance of the folate, the vitamin B9, not only for the pregnancy and the prevention or the reduction of the risk of NTDs, but also the folate usually have much more important effect or functions inside the body, like the proper immune function, like the homocysteine metabolism. It can reduce the stroke and cardiovascular problems due to the metabolism of homocysteine. The adequate folate intake reducing the tiredness and fatigue, so it can actually improve the well-being. The symptoms and signs of folate deficiency can seen as a fatigue or tiredness, weakness, forgetfulness, irritability, and the benefits of folate can be confirmed by multiple studies to reduce the risk of NTD. Some studies show a benefit in autism, Alzheimer's, stroke, and cardiovascular diseases, depression, diabetes type 2, and the triglyceridemia, and in cancer, especially colon cancer. We'll talk about NTD. So it presented with Dr. Wissam from the King Faisal registry. And we have to actually focus on the importance of timing. When the woman knows that she is pregnant, it's only less than 2 weeks time left to start folate. And this is not enough time according to all the guidelines like in US or in Europe. They need more than 1 month before conception and 2 to 3 months throughout pregnancy. And even they said that the increase of the preconception folate from 1 month to even 3 months may actually achieve a maximum NTD risk reduction. And with the 400 nanogram per ml or 900 nanomole per liter, we can see that NTDs was significantly reduced by almost 70 or more than 70%, as mentioned in certain studies. So why we add folate to contraceptive pills? Actually, it helps us to target the proper segment of women in reproductive ages, especially the spacers. So they are planning to get pregnant when they just stop the medication. So they got a proper folate level, and they can get into the pregnancy with a proper folate. The timely intake, so we are not afraid of the 28 days or the 2 weeks left to women. And the kind of the regular intakes, because when oral folate supplementation is prescribed to women, studies found that more than 50% are not taking it regularly, so they cannot even achieve the required level of folate. So with regular intakes, because of the contraception, it might help reaching a proper level with YES Plus. And we can see here that with YES Plus, when we stop the medication for pregnancy and start folate, the level is already high. But if we use a contraceptive pill without folate and we start the folate later on, we might not have enough time to reach the proper level of folate, and the NTDs can really happen. Lastly, what is the difference between different forms of folate, like the metafolin and folate? Metafolin actually is the active form of folate, so it doesn't need any enzymatic metabolism to convert to the biological active one. So individuals with genetic variants of folate converting enzymes can benefit from metafolin, not from folate. Some other benefit of metafolin or tetrahydrofolate rather than the folic acid, it has a lower potential to mask the vitamin B deficiency symptoms. To conclude, actually, with the 24/4 regimen, we can see higher ovarian suppression, higher contraceptive effectiveness, and lower hormone withdrawal symptoms. With the drospirenone, the anti-mineralocorticoid effect can reduce the water retention and improve actually the negative effects like mood swings. And with the anti-androgenic effect, it can treat moderate acne and improve the overall skin condition. Folate part can reduce the risk of NTD, and it can actually enhance the well-being as well. Thank you very much. And any questions?
Thank you very much, Dr. Khalid, for your lecture. Now we'll open the panel discussion. So if anyone wants to add anything from all our speakers, so please proceed. If you want to add anything, so please proceed before breakfast. Any comment? Dr. Wissam, you are the first one started. So do you want to make any comment?
I think this was an excellent, like very rounded mini symposium with a lot of different aspects that were covered. Things that I was, I learned a lot because I don't usually do a lot of like, you know, REI and endometriosis and all these things. So I really benefited a lot. And thank you, Khalid, also for the presentation on the contraceptives, which was also something that once in a while we need reminders of what to use and what is the efficacy and how to actually counsel women with regards to the contraception. So it was a great, I mean, the way I saw it was a great mini symposium. I answered a lot of the questions that pertain to my lectures on the questions and answers, so you'll find them there. And thank you, Dr. Samir.
Thank you, Dr. Wissam. Any additional? Okay. I would like to thank everybody for sharing with us, and it was a great pleasure for all of us. Thank you very much, and happy Ramadan for everybody.
Thank you.
Thank you.
Thank you all.
Thank you.